Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay, the index case. Let's go back to the index case. So again, she's OB, 35-year-old, pre-gravid. She's already served 37 and 1 week each of the station. Now we add this part. Kapag nag-report tayo ng diagnosis natin, we start with the presentation, cephalic, pwede rin tong breech, pwede rin transverse, yon. And then we mention if the patient is in labor or not in labor. So patient natin na to, she is not in labor. Anong technical definition mo ng labor? Essentially, labor means contractions leading to progressive cervical dilatation. Okay? Yun yung simple definition mo ng labor. And as I mentioned, meron siyang GDM, di ba? Na mention ko to, kaya natin siya pinadopplers nung second trimester. So this patient has gestational diabetes mellitus and then diet control yung kanyang GDM. Tapos meron niya siyang oligohydramnios kasi yung AFI niya ay 2 centimeters plus she's elderly pre-gravid based on her age. Okay, just a note on oligohydramnios and diabetes mellitus. Most patients nagpo-polyhydramnios sila, but GDM could go both ways. Pwede rin kasi siyang makakos ng uteroplacental insufficiency which could lead to oligohydramnios. So most likely that's what happened in this patient, no? So instead nandun siya sa other end of the spectrum, nagkaroon siya ng chronic insufficiency leading to oligohydramnios. So now you refer this patient to the resident and then the resident told you we have to admit the patient for induction of labor. Please do CST. Okay, yan yung response niya sa'yo. So what are your indications for labor induction? So tingnan natin yung mga indications and ano din nasa patient natin, why we're inducing for labor. Okay, so when you say labor induction, you are trying to induce labor or induce contractions in a patient na hindi nag-labor. Remember itong patient natin, diba? Cephalic, not in labor. So wala siyang own contractions niya para mag-produce ng cervical dilatation. That's why we induce her labor. Eh bakit natin i-induce, doktora? Ano bang indication? So ito yung mga some of the indications for your labor induction. Essentially, kaya ka nag-i-induce ng labor. This is because your fetal well-being will eventually be compromised if you prolong the pregnancy. So itong patient natin, term naman na siya, but she has oligohydramnios. So hindi na enough yung amniotic fluid volume niya inside. So meron tayong indication to deliver the baby because otherwise, this baby could have non-reassuring fetal status eventually. So hindi ko na isa-isahin yung mga comorbid conditions. So before may pre-eclampsia kayo guys, i-induce na tayo agad. Remember, may timing of delivery tayo for your pre-eclampsia, gestational hypertension, chronic hypertension. So balikan nyo yun. So when you do labor induction, we look at the age of gestation of the patient plus the comorbid conditions of the mother because it's always a balancing act between the fetal and the maternal well-being. Okay? So hindi naman porke ma-observe natin tong GH and pre-eclampsia in the mother, ay hindi na maganda yung uterine environment for the baby, let's induce. We still look at the age of gestation. Okay? So hindi na natin isa-isahin to, but basically we're inducing the labor of this patient because she's already turned and she has oligohydramnios. So yun yung indication, one indication kung bakit tayo mag-labor induction. Doctor, how is labor induction different from augmentation of labor? When you say augmentation of labor, kusang nag-labor yung patient mo. Continuously nag-labor siya, however, pwedeng slow yung progress ng labor niya. That's why you're augmenting. That is why you are increasing the contractions of the patient or you're trying to increase the frequency or the intensity of your contraction para mas mag-progress yung labor. So yun yung difference niya. Sa labor induction, hindi nag-labor on her own si patient. Sa augmentation of labor, nag-labor naman siya on her own except hindi siya ganun ka nagpo-progress. That's why we are augmenting. Dinadagdagan natin. Okay? We're trying to help the mother in her labor process. Okay, let's move on. Okay, sabi diba ang order sa'yo ng resident mo, admit the patient and do CST. What is your CST? CST stands for contraction stress test. If your non-stress test has no contractions, non-stress, walang stress. Ito naman, you are actively inducing stress by inducing contractions. So ano ba itong contraction stress test or CST? So when you do CST, this is a test for uteroplacental function. So tinitingnan mo kung kaya ba ng uteroplacental unit mo ma-withstand ang contraction. So yung patient na hindi na contract, you induce contractions, titingnan mo kung kaya ba ng baby na ma-endure ang labor. Okay? So yun yung contraction stress test. So this is a test for the uteroplacental function. So ano ang satisfactory test? A satisfactory contraction stress test or CST, there should be 3 or more contractions lasting for at least 40 seconds in a 10-minute period. Pag hindi ito na-fulfill, unsatisfactory yung CST mo. So how do you induce contraction? Paano mo sin-stress si baby? Okay? You can do this either through oxytocin infusion. So you start an oxytocin drip for your patient to get these contractions. Or you can do nipple-stimulation. Okay? Tapos i-hook mo yung patient to a cardiotocograph machine. So doon matitingnan yung response niya to stress, yung response niya to contraction. Okay? Nag-get? So how do you interpret your CST or your contraction stress test? Ito. So CST, ang gusto natin na result ay negative CST. So ito yung one test na kapag nakakuha ka ng negative result, that is actually a good result. Yun siya. Bakit? Ang positive CST kasi is there are late deceleration following 50% or more than half of your contraction. So it means that you have uteroplacental insufficiency. Remember that your late decelerations, they're a marker that you have uteroplacental insufficiency. So kapag meron kang greater than or equal to 50% of the time na late deceleration following each contraction, following the contraction, it means na positive CST, positive na stress yung baby mo. So you don't like this. What we like is a negative CST. So these are the other interpretations of your CST. So equivocal suspicious, this means na may intermittent, late, or significant variable deceleration. So hindi mo siya na-observe more than or equal to half of the time na may contraction ka. Equivocal hyperstimulatory. So anong ibig sabihin to? There are decelerations in the presence of contractions more frequent than every 2 minutes or lasting longer than 90 seconds. So hyperstimulatory meaning sobrang dami mong contractions or sobrang haba ng contractions mo. Hyperstimulated yung uterus mo. Kaya naman siya nagde-deceleration. Kaya siya equivocal. If you don't know if it's because of a bad uteroplacental unit or dahil ba nasobrahan ka lang sa pag-stimulate. Okay? Kaya siya equivocal hyperstimulatory. Unsatisfactory is kapag hindi mo na-fulfill yung criteria ng satisfactory contraction. So ito diba yun? Dapat 3 or more, 40 seconds or more in a 10-minute period. Okay, so for example, this patient has a negative CST. So we have, okay, may go signal tayo. Okay to, kung patient na ito ma-withstand niya yung stress ng labor. Pati si baby ma-withstand niya kasi okay yung uteroplacental unit mo. Negative CST. So anong next question sa'yo ng resident mo? Okay, did you perform IE? Yes po, doktora. What then is her bishop score? Guys, ano yung bishop score? Yan. Una, ano mo yung IE findings mo? So say ito yung IE findings mo. Ang bishop score ay depende sa interpretation, sa scoring nitong each finding mo for your cervical findings sa IE. Okay, na-mention ko na itong mnemonic na to kanina, call PEDS. So si call PEDS actually siya ang mnemonic ko for your bishop scoring. So ito ang components ng bishop score mo. CPEDS, consistency, position, effacement, dilatation or dilation, and station. So hindi ko na isa-isahin kung ano yung description for each. So a bishop score of at least 9 means na you have a goal signal for labor induction. If you have a score of 4 or below, it means that you have an unfavorable cervix, and this is an indication for cervical rightening. So ano bang ginagawa natin when we do labor induction? Most of the time, when we do labor induction, we hook the patient to an oxytocin drip to increase the number of contractions or the strength of the contraction or the frequency of your contraction. So imagine guys, if you are trying to increase your contractions against a closed cervix or an unfavorable cervix. Ang point kasi ng contractions mo, di ba? Labor means contractions leading to progressive dilatation, cervical dilatation. So imagine mo kung matigas pa yung cervix mo at pinapakontract mo lang siya. This will induce stress in the baby. So magiging hypoxic lang yung baby mo when you perform this. Why? Because every time your uterus contracts, nababawasan yung blood flow to the baby. So kapag halimbawa, masyado marami yung contractions mo or you are making the uterus contract tapos hindi naman bumibigay yung cervix mo, you are inducing a hypoxic environment for your baby. So we don't like that. That is why we do bishop scoring first. We assess the cervix first to see if the cervix is favorable. Kasi kapag unfavorable siya, we might have to do cervical rightening. Okay? So ang cervical rightening, mamaya papakita ko yung method for cervical rightening. Essentially, you're making the cervix more favorable, mas madali siyang i-open by your uterine contraction. Nag-get? So guys, these are the cervical factors of your bishop score. And unfortunately, kailangan natin isa-isahin to dahil nga tinatanong ko sa board exam. Okay? Pinaka-compute ko yun ng bishop score sa board. So, kailangan na, ngayon pa lang, familiar na tayo sa scoring. So, I'll give you one way of memorizing this. This is how I memorize this during residency. Remember, yung mnemonic natin is called PEDS. C and P yung first component. So, tingnan nyo to. Si C and P, si consistency and position, qualitative sila. Walang numbers involved sa kanilang scoring. So, tatlo lang sila. Yung qualitative na cervical factors, tatlo lang yung pwede niyang description. So, sa consistency, firm, medium, soft. Ang scoring mo, 0, 1, 2, 3. So, hanggang 2 lang siya. Wala kang 3 na score for your consistency. Same as for the other qualitative na cervical factor, which is your position, posterior, mid-position, anterior. So, ito din, 0, 1, 2 lang siya. Wala kang 3. So, tatlo lang yung kanyang binibigyan ng scoring na definitions or description sa C at P. Yung first two components ng call PEDS. Okay, so sa next, yung dilatation, effacement, station. So, parang lang naman i-memorize. Paano naman yun? Okay, ganito guys. Ang key dito, para madali nyo siyang matandaan, you look at kung ano yung nabibigyan mo ng score na 0 at ano yung binibigyan mo ng score na 3. Kapag na-memorize mo kung ano yung nabibigyan ng score na 0 or nabibigyan ng score na 3, madali nang maalala yung mga in-between. Nag-get? So, for example, nung resident ako, ang memorize ko lang na for you to get a score of 0 for your D component, your dilatation, kailangan close. Para mabigyan ka ng score na 3 greater than or equal to 5. So, therefore, may isip mo na yung may score na 1 is 1 to 2, tapos yung may score na 2, 3 to 4. Nag-get? Okay. So, ganun din sa effacement. So, ang score of 0 mo ay 0 to 30%. Ang score ng 3 mo ay greater than or equal to 80. Therefore, ang score ng 1 is 40 to 50. Ang score na 2 is given to 60 to 70% effacement. For your station naman, ang score na 0 ay minus 3. Ibig sabihin sobrang taas. Sobrang taas pa ng cervix mo. Minus 3. Tapos ang score na 3 ay plus 1 plus 2. Note guys na walang station 0. Saan po siya nilalagay, Doktora? Sa 2 namin siya nilalagay pag station 0. Kasi dapat pag score of 3 ka na, dapat beyond ka na ng SQL points mo. Okay? So, plus 1 plus 2 ay given a score of 3. So, nagets nyo, kung i-memorize nyo to in that way, madali na lang ma-memorize yung mga in-between na numbers. Okay? So, remember, the first two components of call PEDS, hanggang tatlo lang siya na values, 0, 1, 2, 3. That's qualitative siya for medium soft, posterior, medium, anterior. Tapos, sa mga may quantitative na interpretation for your IE, siya ay dapat, ang memorize mo, kung ano yung may score na 0 at kung ano yung may score na 3. And in between, madali na siyang madali. Okay? So, ganyan na siya i-memorize. So, again, 4 or below, you do cervical rightening first. So, sa patient natin, anong bishop score niya? So, cervix is 1 centimeter dilated, so bishop score of 1. She is uneffaced, so 0%. So, score of 0. Medium consistency, so that's a score of 1. Tapos, posteriorly placed yung cervix niya, so score of 0. Head at station minus 3, 0. So, you have a bishop score of 2. So, therefore, yung patient natin, si OB, we have to do cervical rightening first. We can't give oxytocin drip right away. So, paano tayo nag-cervical rightening? So, we do this either mechanically or pharmacologically. So, these are the ways by which you could do cervical rightening. Dinoprostone, misoprostol, nitric oxide donors. Dito sa tatlong to, ang usually na makikita nyo in practice is ito, si dinoprostone. Si misoprostol is an abortifacient na commonly used in our region. So, this is banned actually in the Philippines. Wala kayong legal na makukuha ng misoprostol sa Pilipinas. So, one way of doing cervical rightening is to do it mechanically through a trans-cervical catheter or through your hydroscopic cervical dilators like your laminaria. So, yung laminaria, i-insert mo siya into the endocervical canal and then the laminaria will absorb the water from your cervix. So, lalaki yung laminaria, so idadilate niya yung endocervical canal mo. Alright? So, these are your different methods for cervical rightening. So, sabihin natin, nag-dinoprostone tayo kay patient, no? Okay. So, mamaya na tayo, balikan natin si dinoprostone. So, sabihin ng resident sa'yo, okay, nag-cervical rightening tayo kay patient. So, kailangan i-monitor mo si baby. How often should you assess the fetal heart tones of your patient? So, this depends on the stage of labor and the presence of comorbid conditions in the mother. So, first, ano muna yung stages of labor? Okay, so these are your stages of labor. The first stage is the stage of cervical effacement and dilatation. This starts when there are already contractions causing dilatation and it ends with full cervical dilatation. Okay, so kung patient natin 1 centimeter dilated na siya, so that's the first stage of labor siya. Your second stage of labor is from your cervical dilatation to fetal delivery. Your third stage is immediately after the delivery of the fetus to placental delivery. So how do we monitor? Depende kung may comorbid condition si mother. Kung wala, during the first stage of labor, you monitor her every 30 minutes. Now, kapag fully dilated na yung cervix mo, up to the point na mag-deliver yung baby, you monitor the FHT at least every 15 minutes. Pag may comorbid condition, so itong patient natin, di ba, GBM siya, may oligohydramnios siya, so very high risk. The first stage of labor, every 15 minutes. Obviously, mas frequent siya. And then during the second stage, every 5 minutes. So, paano mo monitor yung FHT? Either through your Doppler, your stethoscope, also interpret it every 15 minutes or every 5 minutes, or at least after every contraction. Yan. So ito talaga, every after contraction, or using this time component or this time stamp. Okay. Now, after 6 hours, so usually pag nagbibigay tayo ng dinoprostone, ang repeat IE natin is after 6 hours, you reinterpret you do repeat IE, tapos you look at the trace of the patient. Now, on IE, she's already actively in labor. She's 6 centimeters dilated, and ito na yung trace ng patient mo. Okay? Okay ba itong trace niya? So, sabi sa'yo, paki-interpret naman yung trace. So, after 6 hours, actively in labor na si baby at si patient, ano yung interpretation mo sa trace? So, again, balikan ulit natin yung mga components ng tracing. What should you note in the trace? So, ang baseline fetal heart rate natin for this trace is 130 to 135. So, balikan lang natin yung line. Okay, so in increment of 5, if you put a line across the fetal heart rate pattern, around 130 siya. So, ang interpretation ko dito, 130 to 135. So, this is normal. We see that there are fluctuations na maganda naman. So, we say that this has moderate variability. May accelerations ba? Yes. Ayan, no? Daming spikes in your fetal heart rate. So, there are accelerations. There are no visually abrupt or gradual decrease in your fetal heart rate. So, there are no decelerations. And your contractions. So, paano mo i-interpret yung contractions? So, yung contractions mo, they seem strong. They not seem strong. They are strong. Okay? You have strong contractions coming in every 2 to 3 minutes. Okay? So, pwede mo rin i-mention kung gaano katagal yung contractions mo. Although ito hindi ko na nilagay kasi wala ko ng mga small boxes to completely say, to completely interpret kung ilang seconds. Pero roughly siguro mga 60 seconds po. Yung kasi mukhang isang line, isang box na ganito yung duration ng contractions mo. So, ang full interpretation ko for the contractions is we're having strong contractions every 2 to 3 minutes lasting for 60 seconds. So, for this patient, bakit sinasabi na strong yung contractions niya? So, as you noted, quantitative yung pagkaka-describe ko sa contractions, no? So, ang ano lang naman namin dyan, ang marker lang namin dito is, kung magdodraw ka ng line sa gitna, yun yung moderate ko. Okay? Yun yung moderate. So, less than the line in the middle is mild contractions. More than that is strong. Okay? So, ito strong na strong, no? Abot na nga yung dulo ng parang last line, okay? Dito sa contraction part ng iyong CTG. Okay? So, pero paano ba talaga quantitative na interpretation ng contraction? Ang quantitative talaga na interpretation for your contraction is in terms of your Montevideo units. You see that ang Montevideo units, ang contractions are adequate if within 10 minutes, meron siyang at least 200 Montevideo units. Why am I not describing my trace in terms of Montevideo units? The reason for this is because external yung probes natin. Ang Montevideo units talaga, if you have to be strict about it, dapat internal siya. May mga internal catheters kasi. To really check kung ano yung exact millimeter mercury ng contractions mo. So, ang Montevideo units, for example, internal tong catheters natin na to, from 1019 to 1029, ito yung ano natin, di ba? Ito yung 10-minute gas natin, trace natin. Ang gagawin mo is, you will add the millimeter mercury ng each contraction na makikita mo within that time period. So ito, 100 milli, di ba 100 millimeter mercury siya? So sabihin natin 100, 400, 100, 400, so 100, 200, 300, 300, 400. Okay? So sabihin natin 400 siya. Tapos ima-minus mo itong mga millimeter mercury na to, yung baseline millimeter mercury. So babawasan natin ng 8 to 10. So 400 minus 10, 20, 30, ayun. So meron kang 370 Montevideo units. Yun yung Montevideo unit. But again, to be technical about it, hindi natin siya ma-interpret in Montevideo unit since hindi naman internal yung catheters na ginagamit natin in most clinics or in most labor rooms, okay? Pero kung titignan mo to, kung ito man ay internally, halimbawa ito ay naka-internal catheter, mukha naman siyang adequate, no? Kasi ito pa lang 200 na to, itong dalawang to. Sorry for my poor math. Anyway, in the 3-tier classification system of your traces, this is considered a category 1 trace. Kasi lahat ng components niya ay within normal. Okay? Yung basic fetal heart rate, yung variability, yung acceleration, yung deceleration, and well, yung contractions hindi naman sa part ng interpretation, but these 4, they are all within the normal interpretation or the normal findings of your tracing. So, since normal siya, it is considered a category 1. So, category 1 trace is a normal trace. So, you are having, you have a baby with a reassuring fetal heart rate pattern. So, good ka dito. So, for this patient, mag-monitor lang tayo ng progress of labor. So, magbibigay ka ba ng oxytocin sa patient na to? Do you need to give oxytocin for the patient? No need. Kasi adequate yung contractions mo. If you give oxytocin pa in cases like this, ang mangyayari sa'yo, pwede kang magkaroon ng tachysystole. So, when you say tachysystole, there are more than 5 contractions in a 10-minute window. So, bakit ayaw natin ng tachysystole? Again, every time you contract, you are decreasing the blood flow to the baby. You are inducing a hypoxic episode. So, labor induction is actually a balance between inducing or producing contractions and making sure na hindi mag-hypoxia yung baby mo. So, ayaw natin silang ma-push to tachysystole. Otherwise, you will get a baby with a non-reassuring fetal heart rate pattern. Naget? So, ito, adequate contractions. Watch out lang natin yung mga abnormal fetal heart rate pattern. Monitor the progress of labor lang tayo for this patient. Now, another interpretation in your 3-tier classification system is category 3. A category 3 is an abnormal trace. So, ano yung mga criteria mo for category 3? Dalawa lang yan. Either this or this. Okay? So, nahin natin itong pattern na to. Category 3 trace is one with absent variability. So, tingnan mo to. Meron siya lang absent variability. Hindi mo naman determine or ma-detect yung fluctuations sa baseline fetal heart rate pattern with any of the following abnormalities, either recurrent late or recurrent variable. So ito, is this late or variable? So hindi porque they occurred after the contractions ay late deceleration na siya, no? Kasi abrupt yung pagbaba niya and V-shape yung configuration. So to me, I would interpret this as recurrent variable deceleration. So this patient has absent variability with recurrent variable deceleration. So this is a category 3 trace for me. So another abnormality that could accompany your absent baseline variability is your bradycardia, fetal bradycardia. So, kung hindi naman ganito, yung other tracing na merong category 3 interpretation is this one, a sinusoidal pattern. Yung sinusoidal pattern, very distinct tong pattern na to. Smooth siya na sine wave. Okay? Ganyan, sine wave. Kapag nakakita ka ng sinusoidal pattern, you are now dealing with a baby with fetal anemia, severe fetal anemia. Doon mo siya nakikita. So, kailan nangyayari yun? In cases of abruptio placenta or when your placenta detaches before the fetal delivery. Pwede rin meron kang placenta previa. So, nag-bleed yung mother, so nag-bleed out na rin yung baby. So, when you see this pattern, makakakena. It means that you're dealing with severe fetal anemia already. Okay? So ito lang yung two patterns mo for your category 3 or your abnormal trace. So ano yung mas-skip mo, Doktor? Bakit walang category 2? Essentially, lahat ng trace na hindi category 1 or normal at hindi category 3, lahat yun nagpo-fall under category 2. So ang i-memorize mo lang is category 1, kung ano yung normal, at itong dalawang patterns na to for your category 3. Malinaw? Okay, so yun lang. Yun yung dalawang i-memorize natin. Okay, so kapag meron kang category 2 or category 3 tracing, anong gagawin mo, Doktor? CS na ba right away? Hindi naman. You have room for intervention. So essentially, when you perform these interventions, what you're trying to do is to increase the blood flow to the baby, thereby increasing the oxygen supply to the baby. So ano yung mga interventions na yun? So one is doing, asking the mother to shift to a left lateral decubitus position. So by doing this, nababawasan mo yung travel compression. So syempre, matataas yung uterine blood flow. So another way is administering your maternal oxygen. So obviously, in-increase mo yung oxygen flow to the baby in this manner, or by hydrating the mother, or by giving intravenous fluid bolus, reducing uterine contraction, discontinuing your oxytocin. So ito is you're reducing the contraction. Kasi remember, di ba, the contractions will decrease the blood flow to the baby. So by reducing the uterine contractions, you are increasing the oxygen support to your baby. Repositioning the mother, amnio infusion, this is one method of increasing your amniotic fluid. So usually ginagawa natin to for cases of variable deceleration para mabawasan yung cord compression mo. Okay? So with cord prolapse, ito, manually elevate the presenting part. So we push up the head para hindi niya ma-impinge yung prolapsing na umbilical cord while preparing for immediate delivery. Doctor, how does this happen? So habang nag-IE kami, meron talagang habang nag-CS kami rather, merong internal examination position sa patient to lift the head para hindi niya ma-compress yung cord. Okay? So these are your interventions for your abnormal tracing, like your category 2 or your category 3 trace. Alright? Okay pa kayo, guys? So medyo mahaba talaga yung OB kasi karamihan ng patients namin, kapag nag-rotate kayo sa department namin, mapapansin nyo, karamihan ay OB cases. So marami din namang gyne, pero sobrang extensive kasi talaga ng cases ng OB. Ang daming pwedeng mangyari. Okay? So recap lang muna tayo ng mga na-discuss natin so far. So we discussed history taking and physical examination. We also discussed the workup and others. So nasa others na dito yung vaccination and yung mga konting medications. We also discussed the early pregnancy complications, those that you see around less than 20 weeks. We also discussed fetal assessment and labor induction. So now, we'll proceed to the next part, which is normal labor and delivery. Okay? So ito na kapag nasa labor room, delivery room complex na, yung inyong duty, ito yung mga kailangan nyo malaman. Okay, so first, what is fetal lie? So fetal lie is the relation of the long axis of the baby to that of the mother. So pinaka-common dito obviously is ito, the longitudinal lie. Okay, so yung other types of lie are transverse and oblique. Si oblique temporary lang yan. Usually naging transverse yan or longitudinal. So kasama kay longitudinal, so ba't siya longitudinal, no? Kasi yung long axis si baby same as the long axis ng mother. So si transverse, obvious naman to, nakakahiga si baby. So kailan ka mag-suspect ng transverse? Okay, doon muna tayo. So mag-suspect ka sa transverse on your second buccal, diba? So mapapansin mo na medyo pahaba yung habitus ng baby. And then yung pubic height mo, pwede rin mababa compared dun sa expected mo to the AOG. Remember, 20 to 34 weeks dapat nag-correlate in centimeters sa weeks of AOG. Pero isa to sa mga differential diagnosis mo kapag mababa yung pubic height mo compared with your AOG at this time. So isa to sa mga i-consider mo, lalo na kung hindi naman ganun kaliit yung chan, pero ganun yung measurement mo sa yung pubic height. So as I mentioned, si longitudinal lie, ito yung pinaka-common na lie. So kasama dito si cephalic, just like this picture, kasama dito si breech. Okay? So after the fetal lie, next na kailangan natin malaman is the fetal presentation. So important to, kung papansinin yung diagnosis namin, we say pregnancy uteri, the age of gestation of the patient, the next thing that we mention is the presentation. Then after we see the presentation, we determine if the patient is in labor or not in labor. Okay? So ganun namin sinusulat yung diagnosis. So yung presentation obviously nagpe-present kung ano yung una mong makakapa from your internal examination, di ba? So the most common is cephalic presentation. So these are the different kinds of cephalic presentation. So lahat of guys, even the fifth presentation is a form of cephalic presentation. Kasi nauuna yung ulo mo. Okay? Siya yung nakakapa mo sa pollic grip, di ba? So mga different kinds of cephalic presentation is dependent on the degree of flexion. Like this one, this is fully flexed, and degree of extension. So like this one, the face is fully extended. Alright? So as I mentioned, the vertex presentation, that's the fully flexed version of your cephalic presentation. So kapag partially flexed siya, it's sensipot. So ang makakapa mo dito is the anterior fontanelle. The vertex is the posterior fontanelle. Next is brow presentation. So si brow ang makapalpate mo. This is when the head is partially extended. Pag fully extended siya, you get a face presentation. Remember sa lupus 4, di ba? When you palpate the cephalic prominence on the same side as your fetal back, ang isususpect mo, yung head ng baby mo is probably extended. Kapag naman, on the same side yung cephalic prominence mo as your irregular part, likely the fetal head is flexed. Okay? Okay, now we move on to the next kind of presentation, which is your breech presentation. Now we have three kinds of breech presentation. The first is crank breech. Ito, si crank breech. So ano yung crank breech? So crank breech, your hips are flexed, but your knees are extended. Okay? So parang ganito siya, ganito yung itsura ng crank breech. Next kind of breech presentation is your complete breech. So kaya siya complete kasi both hips are flexed. So your hips and your knees are flexed. The last kind of breech presentation is your incomplete breech or your footling breech. Sometimes we go as far as labeling the incomplete breech as either single footling or double footling. Depende kung ano yung nakakapa namin. So sa incomplete or footling breech, ang nangyayari is one of the hip joints is extended such that yung one of the feet of the baby is presenting. Okay? So gaya nito, di ba? So alin dito sa mga breech presentation na to ang dapat mong isa-target section? Is it flat breech? Is it complete breech? Or is it incomplete or footling breech? So ang isa-target section dito ng obstetrician on duty is the incomplete or footling breech. Why? Because this presentation is high risk for cord prolapse. Isipin nyo, di ba? Mamaya makikita ko sa inyo yung fetal attitude mo. Nandito kasi yung umbilical cord mo. So kapag halimbawa may isa kang extremity na nag-represent before the buttock, ang mangyayari is pwede magkaroon ng entanglement around this area. Ito yung cord yung magpo-prolapse. So kasama siya dun sa extremity ng baby. So we don't want that to happen. That's a very morbid vaginal delivery kapag yun yung nangyari. Compare mo kasi sa single footling breech si footling breech with the complete and the flat breech, ito yung buttock mo para siyang ulo, di ba? So it's a solid structure na pwede bumaba sa pelvic cavity mo sa birth canal mo. So kung mas smooth yung vaginal delivery, mag-flank or complete compared with that of incomplete breech. Alright? Okay, next term that you have to learn is the fetal attitude. Okay, kapag halimbawa nasa-stress tayo, di ba? We say that a person goes to fetal position. Essentially, ito siya. Kaya huwag kayong malito kasi mamaya may i-discuss ako na another fetal position. Yun ang tunay na fetal position sa OB term. Pero in essence, yung fetal attitude, this is the habitus of the baby in birth presentation. Na ito yung habitus mo na pinaka-ideal for vaginal birth, okay? Because kapag halimbawa, yung head mo is extended, that is an abnormal fetal attitude, okay? Ideally, naka-flex siya. So, ito hindi ko naiisa-isa head, but essentially, isipin nyo na lang kung ano yung fetal position na nag-revert ka to when you're stressed. That's the fetal attitude, okay? So, ito ang tunay na fetal position. Okay, sorry for introducing that term, but this is the real fetal position sa OB and normal labor term, okay? So, fetal position is the relationship of an arbitrarily chosen structure in relation to the direction of the mother, whether right or left, anterior or posterior, okay? So, medyo baka malito-lito lang kayo, pero this is the right and then this is the left, okay? Because ang ginagawa natin dito is we're looking at the maternal right and the maternal left. Kung baga, when you say fetal position, halimbawa naka-dorsal dichotomy position, yung mother, and you will sit right in front of the pelvis, okay? So ikaw yung magpapaanak. So ang makikita mo is this one, maternal right, maternal left. Yung symphysis pubis denotes the anterior portion, yung sacrum is the posterior portion. Now, ano yung arbitrarily chosen, okay? Ano yung chosen structures? Depende siya kung ano yung presenting part mo. So in the cephalic presentation, specifically your vertex presentation, ang arbitrarily chosen structure natin is the occiput. So paano mo malalaman na occiput siya? We palpate for the posterior fontanelle. So si posterior fontanelle, siya yung triangular shape fontanelle. Okay, yung malito nga kasi dalawa yung fontanelles natin, merong diamond shape, may triangular shape. Doon tayo sa triangular shape na fontanelle, doon sa mas maliit. So what we do is, when we perform our internal examination, we look for the sagittal suture. So nagsisinislip namin yung fingers namin, tapos hinahanap namin yung posterior fontanelle. So it's this one. Again, it's the triangular shape fontanelle. So that's for your vertex presentation. We choose the occiput. Next is for the face presentation, when your head is fully extended. So ang arbitrarily chosen part natin dyan is the chin or the mentum, okay? And then for the breech, we choose the sacrum. Shoulder, we describe the position of the acromion or the scapula. Okay, so aside from the maternal right, the maternal left, remember we also have yung anterior and posterior. So what if andito siya sa 2 o'clock position? So siya ay left occiput anterior. So in this position, it's right occiput anterior. This one, right occiput posterior. And then this one is left occiput posterior. So dito, sa picture na to, ano yung fetal position natin dito? So you will see here that the head is at the right occiput position. Okay? Kasi ang arbitrarily chosen part, which is the posterior fontanelle, is in this area. Alright? Sige. So ito, exercise tayo. So if I vertex, binigay ko sa inyo vertex presentation, since yun naman yung most common, ano yung position natin dito? Again, huwag tayo malilito, hindi ito. Although ito yung mas malaking fontanelle, hindi ito yung ating arbitrarily chosen structure. What we look for instead is the triangular shape or the posterior fontanelle. Okay? So ito ay occiput posterior. Okay, dali lang yan. Okay, pag ito, so again, nandito yung ating posterior fontanelle. So ito ay right occiput, is nasa maternal right occiput anterior. Kasi di ba mas malapit siya sa symphysis pubis. Okay. So ito, andito yung posterior fontanelle mo. Anong tawag sa position na to? This is the LOT position or the left occiput transverse. So guys, yung left occiput transverse, ito yung pinaka-common na position by which the head enters into the pelvic inlet. Okay? So kaya siya LOT kasi a lot siya. So yung pinaka-madalas or pinaka-frequent na fetal position. Kaya di ba kapag nagpapaanak tayo, kung mapapansin nyo, we turn the baby towards the maternal left, di ba? Pag ganun yung restitution natin. Kasi ang restitution or external rotation, babalik yung baby kung saan siya, kung ano yung position na originally nag-enter siya into the pelvis. So most of the time, it's in the LOT position. So paglabas niya sa pelvic outlet, babalik lang din siya to the left occiput transverse position. Alright? Naginaw ba yun? Mamaya i-discuss ko rin ulit yan sa cardinal movement of labor. Okay, so I'll give you another question. 30-year-old Jan Multifera. On the fourth glucose maneuver, you palpated that the cephalic prominence is on the same side as the convex hard structure palpated on L2. So anong ibig sabihin nito? Likely the head is extended. So, yan, ganyan yung itsura niya. Now, what is the fetal position? Ayan. So, kapag ganito yung fetal position, again, sa face presentation, the arbitrarily chosen structure is your chin. So, we say that this is in right mentoposterior position. You agree with me? Kasi nasa maternal right and more on the posterior siya kasi mas malapit siya sa sacrum. So, this is right mentoposterior. Okay, pag ganito, ano yung fetal position mo? So, the chin is in the left mento-anterior position. Okay, kasi mas malapit sa symphysis pubis, tapos yung chin is nasa maternal left. Okay? Dali lang yan. Okay, let's go back to our index case, si 35-year-old really gravid. On IE, the cervix is already 9 centimeters dilated. Okay, so I have several questions for you guys. First, what is the stage of labor? So madali lang to, di ba? Remember, yung first stage of labor is start of uterine contractions until full cervical dilatation. So that's your first stage of labor. So ito si patient, hindi pa siya fully dilated. So nasa first stage of labor siya. Ano ulit yung second stage of labor? It's from full cervical dilatation to the delivery of your fetus. And then your third stage is from delivery of the fetus to placental delivery. Okay? Next question. Ito nakakalito na to guys. So kailangan ko itong banggitin sa inyo isa-isa. What is the phase of her labor? So iba siya sa stage of labor. What is the phase of parturition of the patient? So anong phase siya of parturition? Yung tanong ko. Last question, nasa ang functional division siya of labor. Okay, so hindi na natin ito. Itong part na ito medyo mahirap na ito kasi madali lang yung stage of labor. First, second, third. So ano itong mga to, doktora? Paano namin sasagutin yan? Okay, doon muna tayo sa phases of parturition. So you have 4 phases of parturition. So kapag sinabi mong parturition, hindi lang yung labor. Labor is part of your parturition. Parturition is yung buong pagbubuntis niya from start of conception, so starting with conception until the fertility is restored. Okay, so my mnemonic for this is quasi. Okay, so parang naisip ko dito si Quasimodo. Kasi parang siyang buntis pero nasa likod. Okay, doon ko lang siya naalala. So quasi because the first part is quiescent. So there is contractile unresponsiveness followed by your activation. So yan yung A. So when you say activation, the uterus is preparing for labor. So dito na tumataas yung mga oxytocin receptors mo. So nagpe-prepare pa lang siya for labor, which is in the third phase or your stimulation phase. Okay? So nandito yung processes of labor. Andito na si 3 stages of labor. Alright? And your last phase is your involution. So, siya na si I, dito sa quasi mnemonic ko. So, your involution includes your uterine involution, your cervical repair, breastfeeding, so until fertility is restored, or this is the part when ovulation is restored, alright? So, ito si parturition, okay? So, huwag kayong malito, iba si phases of labor kay phases of parturition. Si phases of labor ay part lang ng phases of parturition. Si parturition is the entire pregnancy, alright? So, now we'll focus on the third phase, which is the stimulation phase. So, nandito na yung 3 stages of labor as I mentioned a while ago. Ayun na. So, phases of labor, dalawa lang yan. Iba siya kay phases of labor ha? Phases of labor. So, sa phases of labor, you have latent phase versus active phase. So, sa latent phase, kaya sa latent phase kasi mabagal siya, okay? Ang pag-denote natin kung nasa latent phase ka or active phase is your cervical dilatation, okay? Yun yung pinakamadaling way of determining kung nasa ang phase ka na of labor. So, si latent phase, sabi nila, it ends at 6 centimeters. When I was a student, 4 centimeters pa yung active phase. But right now, Williams OB, ACOG, and the Society for the Perinatologists, they say na 6 centimeters na. Now, we had POGS consensus guidelines that was released last year in 2021. Dinidescribe pa rin yung 4 centimeters as active phase, okay? Yung pa rin daw yung start ng active phase. However, may qualifier sila na 4 to 5 centimeters is considered early active phase. Yung true active phase is 6 centimeters. So, bakit po doktora kailangan mo pang i-denote kung early versus true? Okay, pag true active phase ka kasi, doon ka lang pwedeng mag-diagnose ng mga arrest disorders like your cervical dilatation arrest. It's, doon lang yun. Sa arrest cervical dilatation, pag 6 centimeters above lang, mo siya madadiagnose. So, hindi ka pwedeng mag-diagnose or mag-CF during the early active phase just because nag-arrest yung cervical dilatation during this phase. Because according to studies, matagal yung duration between 4 to 5 and between 5 to 6 centimeters. Kaya nagkaroon ng bagong threshold for active phase, okay? Nagbago tayo eventually, naging 6 centimeters from 4 centimeters. So essentially, pag sinabi yung latent phase, kaya sa latent phase, kasi magbagal pa yung progression mo from one cervical dilatation to the next cervical dilatation. What do I mean by this? For example, meron dumating sa'yo na 1 centimeter dilated na patient, technically may kaparapatan-katang magpa-uwi ng patient na yan. Kasi matagal pa, in fact, yung iba hindi mo pa mapipredict yan kung gaano katagal mag-progress from 1 centimeter to 2 centimeters, from 2 centimeters to 3 centimeters. So pag sinabi mo nasa active phase na siya, ibig sabihin, mabilis na siya mag-progress from 1 centimeter, from this centimeter to the succeeding centimeter. Okay? Nag-get? So, we determine that as 6 centimeters now. Clinically, ito talaga yung significant sa amin na active phase dilatation. Alright? I hope that's clear. Okay. So, si Friedman, he described active phase in terms of 3 phases. So, in pa niya, hinimay pa niya yung active phase. So, there is what we call an acceleration phase, a phase of maximum slope, and a deceleration phase. Okay, so ano yung significance na itong different phases na to? So, si acceleration phase, kung papansin niyo, may biglang upslope. No, biglang bibilis dito yung pag-dilate ng cervix. Si phase of maximum slope, ito yung steepest slope, no? So, ito yung pinakamabilis na progression ng dilatation ng patient. So, sa deceleration phase naman, kaya sa deceleration, kasi mabagal na yung progression ng cervical dilatation. However, ano yung significance sa deceleration phase? During the deceleration phase, this is where you expect descent to take place. Okay? Ibig sabihin, bababa na yung fetal head into the birth canal. So, yun yung ano natin, yun yung marker natin na bababa na siya. Deceleration phase, nasa guidelines natin, 8 to 9 centimeters. That's your deceleration phase. Okay? Now, let's move on to the phases of labor. So, ito, paulit-ulit na natin itong ginagawa, pero essentially, pinapakita ko lang sa inyo kung ano yung first stage of labor in the Friedman curve. So, di ba, ang first stage of labor is from the start of uterine contractions na probably nyo nakita dito to full cervical dilatation. Full cervical dilatation to kasi kung titignan nyo, yung nasa y-axis, siya yung 10 centimeters. So, itong part na to dito, nag-stop yung first stage of labor because the latter part is your second stage of labor. So, full cervical dilatation until fetal delivery. Alright, doon naman tayo sa functional divisions of labor. Yung functional divisions of labor, tatlo yan. So the first is your preparatory division. So when you say preparatory division, nag-prepare yung cervix mo, yung uterus mo, for the next part which is the dilatational division. So yung preparatory division, it corresponds to your latent phase and your acceleration phase. Your dilatational division, ang pinagkakaabalahan ng katawan mo dito is kailangan ma-maximize niya yung progression ng cervical dilatation. Okay? So kung si preparatory, nag-prepare pa lang yung cervix mo dito, si dilation, ito yung focus ng katawan mo, mag-dilate yung cervix, yung focus niya. So pagdating mo sa part na to, sa deceleration phase, you go into the pelvic division. So, kung ang pinagkakaabalahan ng katawan mo dito, sa orange part na to is yung pagdadilate niya, pag-open ng cervix, sa pelvic division, ang pinagkakaabalahan niya ay bumaba yung baby into the birth canal. That's why it's called the pelvic division. Pumapasok na siya into the pelvic cavity. Note na yung pelvic division is coincided with your deceleration phase. Okay? Remember what I told you a while ago about the deceleration phase? This is the part where you expect fetal descent. Again, ilang centimeters yung deceleration phase? This is from 8 to 9 centimeters according to the POGS consensus or the POGS guidelines. Alright? Malinaw? Sige. So, the preparatory division, one thing about the preparatory division is, pwede pa siyang mapatagal by sedation and conduction analgesia. That is why, kung papansin niyo, yung mga obstetrician, gynecologists, hindi yan nagpapa-epidural kapag yung patient ay 4 centimeters lang. Bihirang-bihira ka makakita ng ganong OB. Unless may indication ka to do pain management early on. Like, for example, meron kang gravidocardiac patient. So, may sakit sa puso yung patient mo, ayaw mo siyang ma-stress, magpapa-epidural ka ng maaga. But as much as possible, we convince our patient na doon na sila sa pag 6 centimeters na sila or pag 7 centimeters, mga ganon. Pag active na yung labor nila, saka lang kami magpapa-epidural anesthesia kasi we don't want to prolong the labor of the patient. Okay, so anong difference in dilatational division and preparatory division? This division, the dilatational division onwards, hindi na yan affected by sedation. So the last part of pelvic division, this is where the cardinal fetal movements occur. Okay, kasi cardinal fetal movements, ito yung movements ni baby into the birth canal until ma-deliver siya. So yun na yung magiging next part natin. I-discuss ko na isa-isa yung cardinal movements of labor. Alright, so ngayon sagutin na natin isa-isa. So anong phase of labor na to? So 9 centimeters na si patient. So whether 4 centimeters or 6 centimeters yung threshold for active phase labor, siya ay active phase labor. Specifically, nasa deceleration phase na siya, which is between 8 to 9 centimeters. So during this time, dapat mababa na yung fetal head. Now, which phase of parturition na siya? So again, iba si phase of labor kay phase of parturition. Si phase of parturition ay si quasi-mode, quasi. So obviously, hindi siya quiescent, hindi din siya activation, since nag-labor na nga siya, ano na siya sa stimulation, which is the third phase of your parturition. So what's the last phase? Sa I, ano yung I? It's involution. Nagre-recover na siya from labor. Okay, so ano yung functional division of labor niya? Again, ito yung functional division that coincides with your deceleration phase and also where the cardinal movements take place. So ito yung last functional division, nasa pelvic division na siya. What are the other two functional divisions of labor? Preparatory, nagre-prepare yung katawan, and then after that, dilatational division or dilational division, and finally, pelvic division, which is the division, the functional division of labor, kung saan nandun yung patient, since 9 centimeters dilated na siya. Okay, I hope that's clear. Naget nyo ba? Okay, move on. Ayan. So again, as I mentioned, the pelvic division is where the cardinal movement of labor takes place. So what are your cardinal movements of labor? So the first cardinal movement of labor is engagement. So what does engagement mean? So engagement means that your biparietal diameter is already past the pelvic inlet. So bakit ang biparietal diameter yung ginagawa nating marker? It's because it's the greatest diameter in the transverse axis of the head. Mamaya makikita nyo rin siguro pag pag diniscuss ko isa-isa, okay? As it occurs yung cardinal movement of labor. By the way, itong i-discuss natin ng cardinal movement of labor, ito ay cardinal movement of labor in vertex presentation, which is the most common naman. So yun ang muna i-discuss natin for this course. So after engagement is descent. Okay, kailan ulit nangyayari yung descent? During the deceleration phase or during the pelvic division. Okay? So descent meaning bumababa na siya into the birth canal, into the pelvic cavity. So obviously descent is the one cardinal movement that happens all throughout the cardinal movement. Diba? Sabi, hindi ka naman pwedeng lumabas sa birth canal ng ng descent right after engagement. Diba? So tuloy-tuloy yan, descent. It goes without saying, descent. Alright, so next is flexion. After flexion is internal rotation, extension, external rotation, and then finally expulsion. Sige, explain natin yung isa-isa. So unang yung dadaanan is the pelvic inlet. So the pelvic inlet, ang delineation niya talaga is the one that is under the linea terminalis. Okay? So bakit important sa linea terminalis? Yung above kasi ng linea terminalis, and ito diba, this is the edge of your iliac crest. So ito siya. Yan ay false pelvis. Alright? Ang tunay na birth canal, ang tunay na pelvic cavity is below this line, the linea terminalis. So ano yung mga borders mo for your pelvic inlet? So your ila and your sacrum, dito, your linea terminalis, and then your pubic symphysis. Okay? Ito yung nasa anterior border niya. Yan. So yun ang unang yung dadaanan. So when your biparietal diameter, ito yung sinasabi ko, kaya siya yung greatest diameter along the transverse axis. Kasi kung papansin niyo, siya yung widest portion, diba? Yung biparietal diameter. So pag yan ay lumampas na ng linea terminalis, it means na engaged na yung patient. Now, hindi mo naman masasabi, diba? Kung yung nakalampas na yung biparietal diameter, ano yung clinical marker mo na nakalampas na yung head mo, ay yung biparietal diameter mo sa pelvic inlet. Yung nakakapamong OB is the leading part of the head. So kapag ang leading part of the head is nasa station 0, which is your midplane, pag nasa station 0 na yung leading part of the head, it means that the biparietal diameter is already past the pelvic inlet. It means na engaged na siya. Okay? So ganun namin na-determine kung engaged na yung head. Kapag nakakapa namin yung leading part sa station 0. Now, speaking of station 0, yun yung midplane mo. Alright? So mamaya i-discuss ko yung diameters isa-isa. So yung last na kailangan i-overcome ng baby is the pelvic outlet. So ano yung mga important na diameters? Yan. So let's start first with the pelvic inlet. So kapag nag-IE kami ng patient on admission, we also do clinical pelvimetry. Bakit important ang clinical pelvimetry? This tells us the likelihood of the patient kung normal delivery ba siya or kung magdi-discharge siya. Okay? So ang una namin mini-measure is the pelvic inlet dimension. So particularly, ang importante lang sa amin, hindi naman, pero yung na-measure lang namin clinically is your diagonal conjugate. Okay? Ito lang talaga yung na-measure namin. So your diagonal conjugate is the distance between the lower portion of your pubic symphysis up to the sacral promontory. So kapag nag-IE kami, so pag ganyan, no? So imagine niyo yung fingers namin, yung tip ng fingers namin is natay namin abutin yung sacral promontory. Pag hindi namin siya naabot, that's a good sign. It means that your diagonal conjugate is greater than 11.5 centimeters. So, ibig sabihin, hindi masikip yung pelvic inlet. So again, that's a good sign. Once we say na, oy, kapang-kapang yung sacral promontory, okay? Maging suspicious ka na for dysfunctional labor. Pwedeng mag-dysfunction yung patient mo. Kasi hindi siya kasya sa pelvic inlet, okay? Parang ganun yung, yung clinical correlate namin for that. So the other important diameters in your pelvic inlet are your obstetrical conjugate. Now, hindi namin ito ma-measure clinically, but what we do is we subtract 1.5 to 2 centimeters from your diagonal conjugate. So meaning, your obstetric conjugate is around 10 centimeters. So bakit important yung obstetrical conjugate? So kung papansin niyo, yung obstetrical conjugate is nasa yung gitna ng symphysis pubis up to the sacral promontory. So since siya yung sa gitna, siya yung pinakamakipot na diameter ng pelvic inlet. Okay? Dito sa axis na to. So ang true conjugate naman, kaya siya true conjugate kasi siya yung nasa upper border ng symphysis pubis up to the sacral promontory. Ibig sabihin, siya talaga yung true diameter ng pelvic inlet. Kasi siya yung unang mong i-overcome di ba? Pero ang clinically significant is itong si obstetrical conjugate. Pero ang clinically measurable mo lang is your diagonal conjugate. Naintindihan? So bakit clinically significant si obstetrical conjugate? Because it's the narrowest portion dito sa axis na to. Pero again, si diagonal conjugate yan lang ang ma-measure mo, yung manually ma-measure mo on internal examination. Paulit-ulit pero ganun talaga. So para maalala niyo siya yung mga conjugate, DOT, that's my mnemonic. So diagonal, from the ilalim, diagonal, obstetrical, and true conjugate. Alright? Yan. So ganito namin siya mini-measure. Imagine nyo na kung paano namin siya mini-measure. Ayan. So pag nag-internal examination kami, we try to reach for this part, the sacral promontory. So ang maganda na diagonal conjugate is kapag hindi mo naabot yung sacral promontory. We move on to the plane of least dimensions, which is your pelvic midplane. So midplane, siya yung pinaka-kipot, okay? This is the reason why your head has to undergo internal rotation. Mamaya papakita ko sa inyo, i-describe ko sa inyo through the cardinal movement of labor, bakit internal rotation yung makaka-overcome itong plane of least dimensions. That's how the fetal head negotiates into the birth canal by doing internal rotation, okay? So ang anatomic landmark natin for your midplane are your ischial spines. So ito siya. So may bony prominences below the inlet, that's your ischial spines, and we measure the diameter between the two ischial spines. So that's your intersplenius, also called the bisplenous diameter. So if you have a bisplenous diameter of at least 10 centimeters, it means that you have an adequate midplane. Okay? Bakit? Okay, let me tell you na ang typical 9.5. Okay? So if yun, di ba, ang widest na diameter in the transverse axis. So kapag halimbawa 10 centimeters yung biplanar diameter, ibig sabihin, kasha yung biparietal diameter dito sa plane na to, dito sa dimension na to. Okay? Ano pa yung important about the midplane? Particularly the ischial spine. So yung ischial spine, yun yung pang-denote namin ng station 0. Okay? Above the ischial spine, negative yung values ng station mo. Below the ischial spine, positive. Okay? Ano pa? Bakit pa important yung ischial spine? Very important sa amin itong plane na to. Actually, madalas yung mga dysocial namin, well, sa-experience ko sa midplane sila nag-aaret. So isa pang important thing about the midplane or the ischial spines in particular, ito yung anatomic landmark namin for your pudendal nerve block. Okay? So kapag halimbawa wala na kaming time, magpalagay ng epidural catheter or magpa-spinal anesthesia or anong tawag mo doon? Anong tawag mo doon, mami? Yung spinal pero pang OSE?
Name, I'm sorry.
Game. Anong tawag doon, Mavis? Yung pang spinal anesthesia pero pang OSE, instead na makapag-epidural ka. Anong tawag doon? Naisip mo ba?
Hindi.
Naisip eh. Anyway, okay, action. So another important thing to note about the ischial spine is also our anatomic landmark for your pudendal nerve block. So yung pudendal nerve block, ginagawa namin yan kapag wala na kaming time to perform regional anesthesia sa likod, yung mga epidural anesthesia namin, tapos kailangan namin mag-outlet forceps extraction, or kung gusto namin na more than local anesthesia yung analgesia namin for your episiotomy repair, we perform pudendal nerve block. So dito namin, ito yung dinakapan namin for the pudendal nerve block, okay, yung ischial spine. So as I mentioned a while ago, kapag yung leading part of the head is already at the level of the ischial spine or at station 0, then we say na nakapag-engage na yung head or that the biparietal diameter is already past your pelvic inlet. Okay? Nag-get? Sige. Okay, sa labor room, madalas maririnig nyo to. Okay, pag iinip na yung mga residents sa pagpapaanak ng patient, they would sometimes shout, do McRoberts maneuver. Okay, McRoberts. Okay, pag sinabi McRoberts maneuver, ano yung ibig sabihin nun? So first, what do you mean by McRoberts maneuver? So before answering that, let me ask you a true or false question. So true or false? This maneuver, the McRoberts maneuver, increases the pelvic outlet diameter. So the correct answer here is false, and this is according to Williams. So ano muna yung McRoberts maneuver? So McRoberts maneuver, ang ginagawa mo is you hyperflex the hips of the mother such that the legs are pushed towards the maternal abdomen. So ganito, no? So sariling sikap dito si mother. Ideally, may tig-isang assist na nag-hyperflex on each side. So kailan ginagawa yung McRoberts maneuver? Technically speaking, ginagawa mo siya kapag meron kang shoulder dystocia. Ano po yung shoulder dystocia? Ngayon ko lang narinig yan. So when you say shoulder dystocia, it means na naka-impact yung anterior shoulder mo behind the pubic symphysis. So kailan nangyayari si shoulder dystocia? Typically sa cases ng diabetic mother with macroscomic baby. So bakit siya nangyayari? Because in these cases, kadalasan there is truncal obesity, there is fat deposition centrally, so nakakalabas yung ulo, pero nag-i-impact yung shoulder. Hindi siya, kaya sa shoulder dystocia, hindi siya lumalabas agad. Because again, the anterior shoulder, nakalodge siya behind the symphysis pubis. So anong ginagawa natin pag anong nangyayari kapag nag-McRoberts maneuver ka? When you do McRoberts maneuver, ang nangyayari is you straighten the lumbar lordosis. You reduce the lumbar lordosis. So nasa-straighten tong part na to. So aside from that, there is upward gliding of your symphysis pubis, okay? So kung na-imagine nyo, kung nandito yung shoulder mo, because of the upward gliding, lulusot na yung anterior shoulder. Yun ay kung nag-work ang McRoberts maneuver mo sa shoulder dystocia. Makita nyo, nag-move up tong symphysis pubis, okay? So dyan, nawawala yung shoulder impaction through McRoberts maneuver. So mababasa nyo rin sa book, ang ginagawa ng McRoberts maneuver is that it reduces the pelvic inclination angle. Okay? Let me be clear about that. Hindi niya ini-increase yung pelvic dimension. Ang ginagawa niya is dinidecrease niya yung pelvic inclination angle. Ano po yung doktora? So si pelvic inclination angle, ang definition niya is yung angle between the inlet and your horizontal axis. Kaya siya patayo kasi nakahiga na si mother. Naget nyo? So itong axis na to, that's your horizontal axis kapag nakatayo si mother. Tapos itong plane na to, this is the pelvic inlet. So si pelvic inclination mo is this one. Okay? Yan. Yan yung pelvic inclination mo. Now with McRoberts maneuver or by hyperflexing the hips, you decrease the pelvic inclination angle. Naget? So makikita nyo, mag-decrease yung angle na yan. So in effect, from this position, pupunta dito si symphysis pubis. So itong shoulder na to, itong anterior shoulder, ideally, mapipi siya. Okay? Yun ang tunay na definition mo ng McRoberts maneuver. Okay? So in a way, sinisigaw din siya ng resident. Pag gano'n, naiinip na talaga sila gusto nilang mga anak. So inisip nila na yung McRoberts maneuver mas mapapacilitate yung fetal expulsion. Okay? But technically speaking, this is a maneuver reserved for shoulder dystocia. Malinaw? Alright, so now we move on to the actual step-by-step discussion of your cardinal movements of labor. Again, I'd like to clarify that these are the cardinal movements of labor in your most common presentation, which is your vertex presentation. So in vertex presentation, the arbitrarily chosen part is your occiput. Specifically, na pinapalpate namin dyan is the posterior fontanelle. Ano yung shape niya? Triangle, okay? Yung diamond shape is the anterior fontanelle, which is actually the bigger fontanelle. But what we use talaga as a marker is your posterior fontanelle, okay? Okay, so tara, i-discuss natin yung cardinal movements of labor. So I have a question first regarding your engagement. True or false? In the liparas, yes. Okay. In the liparas, nalagay ko yung answer. Anyway, in the liparas, engagement may take place before onset of labor. So as I showed you here, this is true. Okay? Sa liparas, yung engagement descent pwede yung magsabay. But in the liparas, usually engagement takes place before the onset of labor. So this takes place before descent. So hindi pa nag-labor yung patient, pwedeng engage na yung head in cases of nulliparas for your G1, P0. Okay? Malinaw? Alright, so i-discuss natin isa-isa yung cardinal movements of labor. So again, anong definition ng engagement? Engagement is when your biparietal diameter, which is your widest transverse diameter in this axis, ayan, kita nyo ba? Yan, so yung widest diameter sa axis na to, when this diameter is past the pelvic inlet. So ano ulit ang true pelvic inlet? It's beyond your linea terminalis. Ano yung false pelvis? Ang false pelvis, true pelvis yung meaning ko kanina, past the linea terminalis. Okay? So yun yung pelvic inlet. So ang false pelvis is above the linea terminalis and within the upper border of your iliac crest. Imagine nyo ba? Yun. So anyway, below the pelvic inlet, yun yung true pelvis mo. So kapag lampas na doon ang biparietal diameter mo, it means that the head is engaged. So saan mo nakakapa yung leading part? station 0, okay? Level of the ischial spine. That is the definition of engagement. Now, after engagement, there will come descent, okay? So as I mentioned, descent, obviously, it will follow in all the succeeding cardinal movements of the board. So next is flexion. So as the head goes into the narrow birth canal or the narrow through pelvis, kailangan niya mag-flex, okay? Bakit? Originally, yung presenting diameter mo is the occipitofrontal diameter. So typically, 11.5 ang occipitofrontal diameter. So occipitofrontal, yan siya. So 11.5 yan. But what happens when the chin comes in contact with the chest? Magiging suboccipitobregmatic na yung presenting part mo. So this is the bregma, this is suboccipito kasi under the occiput, yan ay magiging presenting diameter. As you notice, mas maikli yung suboccipito diameter compared with your occipitofrontal diameter. Kung si occipitofrontal diameter nasa 11.5, si suboccipito diameter is 9.5. So obviously, that's how the head negotiates into the birth canal when the head performs flexion, okay? So ganun siya papasok into the birth canal. Okay, so what comes after flexion? So what comes after flexion is letter I, internal rotation. Anong ibig sabihin ng internal rotation? So kapag papasok ka na ng plane of least diameter or of least dimension, ano yun? That's your midplane. Ibig sabihin, kailangan na mag-negotiate ng head mo in between the ischial spine, okay? In between the space between the ischial spine. So kaya siya internal rotation kasi kung papansin nyo, itong fontanel from transverse position, iikot siya paloob. Yan. Mag-rotate siya paloob. Kaya siya internal rotation. It's rotating towards the symphysis pubis. Okay? So, paano siya? Bakit siya nangyayari that way? Remember na ang greatest diameter mo is your greatest diameter mo along the transverse axis of the head is your biparietal diameter. So, typically, 9.5 yan sa mga baby. So, kaya mo sinasabi na adequate mid, pelvis, or sa interspinous diameter ay kapag more than 10 cm siya, it's because, ibig sabihin, na-accommodate niya yung greatest transverse diameter ng head ng baby, which is the biparietal diameter. Okay? Nag-get? So, yan. So, imagine nyo, diba? Kaya siya iikot paloob ng ganun is kaya siya ikot paloob ay para mag-negotiate siya into the midplane. Alright? Yun si internal rotation. Now, as nag-descend si fetal head, ang mangyayari is mag-extend siya. Kita nito? Yan. Kita siya. Ayan. Nag-extend na yung fetal head. Ayan. Pinakalabas na yung ulo mo. What happens right after is restitution or external rotation. So, bakit siya external rotation? So, yung posterior fontanel mo, from occiput anterior, magiging babalik siya dun sa left occiput transverse position. Remember, di ba, kung paano siya pumasok sa pelvic inlet, ganun siya babalik upon external rotation. So, most of the time sa left yan, kasi a lot, di ba? LOT, yun siya pumapasok sa pelvic inlet. So, paglabas niya, past the pelvic outlet, mag-rotate siya, mag-externally rotate siya towards the left occiput transverse position ulit. Nag-get? So, kung ang internal rotation mo is paloob pa ganun, kaya siya external rotation is because yung posterior fontanel mo, externally, palabas siya mag-rotate towards the transverse position. Okay? Kaya important na alam nyo yung mga fetal position and yung mga definitions kung paano namin dinidescribe yung mga fetal position. Okay? So, ayan, nag-external rotation ka na. What happens after this? Expulsion na. So, to facilitate expulsion, what we do is, we deliver the anterior shoulder first. So, you pull down the head of the baby, followed by delivery of the posterior shoulder. So, now you pull up the baby. So, ito yung complete cardinal movement of labor from engagement to fetal expulsion. Okay? So, here's a good video that I found on YouTube showing you the cardinal movements of labor. So, yan, i-play natin para ma-appreciate nyo. I-describe ko siya ulit para mas ma-familiarize kayo. Yan. So, what happens here is engagement. So, as you can see, the engagement with biparietal diameter goes past the pelvic inlet. Okay? So, ito si pelvic inlet. Yan. So, this is where the descent takes place. And then flexion as the chin moves closer to the chest para mas maliit yung presenting diameter. And then, at the level of the midplane, mag-internal rotation na siya. So, iikot paloob yung posterior fontanel. And then, as the head negotiates into the pelvic cavity, it will extend until lumabas siya sa pelvic outlet. And then, look at this part. External rotation. Kasi palabas yung ikot ng posterior fontanel. Okay? And then here, you facilitate the delivery of the anterior shoulder, followed by the posterior shoulder. And that's your last cardinal movement of labor, which is expulsion. So, I hope na-get nyo siya. Yan. So, yan yung mga i-expect nyo in birth presentation. Those are your cardinal movements of labor. So, hopefully, dahil alam nyo yung cardinal movements of labor, mas madali yung mamonitor yung progress of labor ng patients nyo or mas ma-appreciate nyo siya. And better yet, kapag nagpaanak na kayo in the labor room, delivery room, mas ma-appreciate nyo kung bakit ganun yung ginagawa nyo, bakit ganun yung technique ng pagpapaanak namin. Okay? So, yun yung significance of learning your cardinal movements of labor. Now, as students in charge of your patient, we will ask you to accomplish a partograph. Okay? So, medyo magulo na baka malito-lito kayo, pero ito yung isang sample partograph ng patient ko. So, we have a 25-year-old pre-gravid. So, usually, we put the admitting diagnosis, final diagnosis, and then I teach the IE on admission. So, ano yung mga parts ng partograph? So, yung mga nasa baba, this is institutional. Parang depende sa institution or sa hospital where mag-duty ka. But, technically, yung mga standard parts ng partograph mo are this, the dilatation along the y-axis. This is from 0 to 10 centimeters or full cervical dilatation. Itong nasa baba, yan yung hours of labor. Okay? So, kapag alam mo kung kailan yung onset of labor niya, yun yung 0. So, ito, kaya siya dotted lines, kaya siya hindi solid line, is because hindi pa na-admit dito yung patient. So, kapag may solid line na siya, yan na yung part na na-admit siya sa labor room. Okay? So, typically, we denote your cervical dilatation with an X. So, para maaalala nyo, X is cervix. Okay? Tapos yung head is for the descent. So, mukhang yung circle is for the descent. So, kaya siya circle, para mas maalala nyo, bilog kasi siya. So, parang siyang ulo. Siya yung descent. So, kung yung nasa y-axis dito sa left is your cervical dilatation, itong nasa right naman, na nasa y-axis, it indicates the station. Okay? So, parang balikan siya. So, sigmoid curve pataas is your cervical dilatation. Sigmoid curve pababa is your descent. Alright? So, usually yung mga nilalagay pa namin sa partograph, but this is for the obstetrician, for the residents na to. The abdominal PE with the estimated fetal weight and other pertinent abdominal PE findings. This is the pelvimetry. Okay? And And then dito nilagay ko yung outcome ng patient. So tingnan natin, isa-isa yung aking pelvic dimensions na yung pelvimetry. So yung diagonal conjugate is more than 11.5 centimeters. So it means adequate yung pelvic index. Yung bisinus diameter ko is greater than 9.5. So yun ang yung dinanote ko. Kasi diba remember yung kailangan mag-negotiate na diameter sa bisinus diameter mo is your BPD, which is 9.5. So hindi ko siya exactly measure na, but it's enough to say na greater than 9.5. So alam ko na kakasya yung head ng baby ko dito. Alright? So spines are blunt. Ano pa yung iba mong description for the spines? It could be prominent. Spines here, it means ischial spines, ha? Okay? So pag sinabi mong prominent yung ischial spines, suspicious ka of mid-plane contraction. Alright? So side walls are parallel versus being convergent. So sacrum is hollow. So it means yung pelvimetry ko na to, this is adequate pelvimetry. So hindi ako nagsususpect ng dysfunctional labor dito sa patient na to or cephalopelvic disproportion. Okay? So ito yung part of that. So ito yung inyong i-accomplish as interns in charge or third in charge of your patient's labor. Alright. So now we go to abnormal labor and delivery after we describe the normal labor and delivery. Ayan. So usually pag may problem ka sa labor mo, it will be one of three P's. So ano yung three P's na pwede mo maging problem? First is problem in power. This means na may problem ka sa maternal expulsion or maternal effort sa pag-push niya or may contractile problem in uterus mo. Second, it will be a passenger. You might be dealing with a very big baby or meron siyang congenital abnormality or malformation that precludes normal delivery, or it could be passage. Baka masikip talaga yung dadaanan ng baby. So what are the possible terms na malilinig nyo when it comes to dysfunctional labor or dystocia? Kasi sinabi mo na FPD. When you say FPD, it means fetal-pelvic disproportion. It means na ang iniisip na problem ng obstetrician gynecologist is more of a passenger problem. When you say CPD, this means cephalopelvic disproportion. It means that your obstetrician is thinking more of a passage problem. Yung dadaanan yung problem, okay? Yung bony pelvis, somewhere there, merong masikip kaya hindi makadaan yung passenger mo. Yan. So these are your CPs for dysfunctional labor. Okay. Now for dysfunctional labor, para madali mo siya ma-diagnose, you have to know kung nasa ang phase ka na of labor, kung nasa ang stage ka na of labor. Yun yung important. Now, I'll describe to you problems in the latent phase. Again, ano yung latent phase? So, iba-iba yan, minsan 4 centimeters, minsan 6 centimeters yung threshold. But for the local guidelines, we'll just say na 4 centimeters yung start ng active phase, okay? So, ang latent phase mo is below 4 centimeters. So, kapag below 4 centimeters yung cervical dilatation mo, you could have problems involving prolonged latent phase. So, ano yung prolonged latent phase? Depende kung if you're dealing with nulipara. Nulipara meaning G1, P0. So, it's more than 20 hours for nulipara. If at least P1 or yon, at least G to P1, parang ganun yung nagiging OB score mo. If that's OB score your patient, greater than 14 hours is the definition of prolonged latent phase for this patient. Now, ano yung preferred management for prolonged latent phase? It's bed rest, okay? So, bilang kami actually mag-admit sa latent phase So, papasadahan ko lang itong dalawa na to. Itong dalawang slides na to ng dysfunctional labor. So, next is, pag may protraction disorder. What do you mean by protraction? Ibig sabihin ng protraction, mabagal, okay? So, ano bang ibig sabihin mo ng protracted active phase dilatation? So, since mabagal siya, yung slope ng protracted active phase dilatation mo is like this, no? Mas mababa yung slope niya compared to the more steep sigmoid curve of your Friedman curve. So, ito kasi dinidescribe niya dito kung ano yung normal or ideal na rate ng cervical dilatation. So, dahil protracted siya, yan yung itsura ng curve mo. Now, protracted descent is defined as less than 1 centimeter per hour for nulliparous, for multiparous less than 2 centimeters per hour. So, kumbaga yung descent mo kasi is hindi na nakadrawing dito sa Friedman curve na to, pero ideally pag ganyan din siya, di ba? So, sa protracted descent, kung i-drawing mo siya, hindi siya yung norm, hindi ito follow yung typical na progression ng descent. So, mabagal siya. Yun yung protraction disorders. So, ano ba ginagawa dyan? That's why I'm not emphasizing this part sana is because expectant and support lang yan. Wala kaming active management. Hindi lang nito makita sa mga diagnosis namin. Okay? Kasi hindi kami ganun ka-active na nagmamanage ng protraction disorders. Kung tingnan nyo nga, di ba, expectant and support, yan yung preferred management for these disorders. So, ano yung mas kailangan yung pagtuunan ng pansin? It's the following disorders. So, first is arrest disorders. Kailan kailang pwedeng mag-diagnose ng arrest disorders? It's when your cervix is at least 6 centimeters dilated. Remember, di ba, sa POGS, iba yung sinasabi nilang early active phase, that's 4 to 5 centimeters, iba yung true. The true active phase is at least 6 centimeters, doon ka lang pwedeng mag-diagnose ng arrest disorders. Meaning, kapag meron kang arrest disorders, and you note that the patient has cephalopelvic disproportion or fetal-pelvic disproportion, that's when you perform abdominal delivery for dysfunctional labor. Okay? Otherwise, hindi ka makaka-call ng arrest disorders at less than 6 centimeters. So, kailangan 6 centimeters talaga. Kaya significant ang true active phase at 6 centimeters. So, that's why it's a significant definition for us. So, anong ibig sabihin ng active phase arrest? So, when you say active phase arrest, this is in fact arrest in the cervical dilatation during the active phase. So, this is reserved for women with greater than 6 centimeters dilatation. Okay, meron siya dapat na ruptured membrane. So, that's a prerequisite. Hindi ka pwedeng mag-diagnose ng dysfunctional labor or dystocia kapag hindi pa ruptured yung bag of waters. Okay, so this is the reason why yung ibang OB, they elect or they opt to rupture the bag of waters at 6 centimeters or when the labor is already in the active phase. Kasi gusto nilang bilangan or gusto nilang tingnan kung magpo-progress yung labor. Alright? So, kapag meron ka ng ruptured membrane, pumuntok na ang panubigan, and you have at least 4 hours na adequate yung contraction, pero hindi nagpo-progress yung cervical dilatation, it means that you have active phase arrest or arrest of cervical dilatation. Nag-get? So, paano po, doktora, kung inadequate yung uterine contractions mo, kahit naka-oxytocin ka na, then you extend the waiting time to at least 6 hours, okay? So, at least 4 hours, pag adequate yung contractions, at least 6 hours kapag inadequate. In terms of Montevideo units, how do you describe adequate contractions? There should be at least 200 Montevideo units within a 10-minute window, alright? So, yun yung adequate contractions. Or, if you look at your case, at least every 2 to 3 na strong contractions, yun, more or less you're having adequate contractions at that point. Okay, so tingnan natin itong case na to. This is an example of your arrest of cervical dilatation. Why? So una sa lahat, G1P0 siya. But actually, same lang naman. Kung nulipara, multipara, for arrest of cervical dilatation, same lang yung time component. So ito, important to. Nag-rupture na yung bag of waters. Kaya rupture membrane at the 6th hour of labor. So on admission, dun nag-rupture yung bag of waters niya. So she has strong contractions every 2 minutes. So more or less, you can see na adequate yung contractions niya. And from the 7th hour of labor to the 11th hour, so this is a total of 1, 2, 3, 4 hours, na adequate yung contraction, pero hindi umalis sa cervical dilatation of 6 centimeters yung patient mo, then you can call this as a case of arrest of cervical dilatation. So, pwede kang mag-cesarean delivery for dysfunctional labor in this case. Nag-get? Alright, so next case naman. Okay, sabihin natin na ganito, yung progression ng labor ng patient mo, 8 centimeters siya. So first question, ano yung phase of labor? Different patient to guys ha, different patient na pero same scenario. Pregnant gravid, ruptured bag of waters on admission, adequate contraction. Una sa lahat, anong phase of labor ng patient? So the patient is in active phase of labor. Why active phase? Kasi diba at least 4 or 6 centimeters si patient, so active phase na siya. Specifically, nasa deceleration phase. Why? Kasi 8 and 9 centimeters, that's your deceleration phase. So this patient is nasa deceleration phase na. So ano ibig sabihin ng deceleration phase? Dapat nag-descend na yung fetal head mo at this point, na pumapasok na siya sa pelvic division. So in terms of functional division, nasa pelvic division na siya of labor, where your cardinal movement should take place. So dahil nasa 8 to 9 centimeters na yung cervical dilatation mo, pasok na siya sa definition mo ng prolonged deceleration phase. Now, magkaiba ulit siya, depende kung nulliparous or multiparous yung patient mo. For nulliparous patient, 3 hours or more means that you have prolonged deceleration phase. Pag multipara, 1 hour or more. Naget niyo ba? Naget niyo yung ano natin, kung paano niyo i-diagnose yung disorders? So, balikan natin yung dysplasia curve natin. So kung halimbawa, meron kang 3 centimeters na patient. So dito, ang papasok ka lang siya sa latent phase disorder. So pwede siya sa mga prolonged latent phase, etc. Okay? Kapag nasa 6 centimeters ka na, yan na yung beginning ng time na pwede ka nang mag-label ng patient na active phase arrest or arrest of cervical dilatation at least 6 centimeters. Pero pag pumasok ka na sa 8 centimeters, since nasa deceleration phase ka na, hindi ka na sa arrest, active phase arrest mag-label ng patient. Papasok na siya sa prolonged deceleration phase. Okay? So doon na siya papasok sa prolonged deceleration phase. So ito, nalipara na 1, 2, 3. So at least 3 hours, diba, yung prolonged deceleration phase. So ito, ganitong labor curve, I will label this as prolonged deceleration phase. So ito may mga questions pa pala ako. So again, ano yung functional division nitong patient? It's pelvic division. In terms of stage of labor, this is still in the first stage. Why first stage? Kasi hindi pa siya 10 centimeters dilated. Diba? So start of uterine contractions up to full cervical dilatation, that's your first stage. Okay? Yeah, so ito, just as I mentioned, this is a case of prolonged deceleration phase. So, paano naman yan? Ibang patient na ito, kunwari high patient. Pero ganito na yung scenario. Walang epidural anesthesia. Nag-full cervical dilatation na siya. Again, questions sa inyo, anong functional division niya and anong stage of labor. So in terms of functional division, nasa pelvic division pa rin siya. Kasi past the deceleration phase. Tapos, ang stage of labor na niya is second stage of labor. Kasi fully na siya full cervical dilatation na. So at this point, pag nag-second stage of labor ka na, important na i-note kung meron kang epidural or wala kang epidural anesthesia. Why? So andun na tayo sa next kind of dysfunctional labor, which is prolonged second stage of labor. So ito is kapag yung cervix mo is fully dilated or 10 centimeters na. So anong definition mo ng prolonged second stage of labor? So sa malipara, 2 hours or 3 hours, depende kung may epidural anesthesia ka. If meron kang epidural anesthesia, mag-extend ka ng mas mahaba sa paghihintay mo. Okay? So si patient natin, kaya importante yung nilagay ko dito na no epidural anesthesia kasi magmamatter siya kung makaka-call ka na ng dysplasia or hindi. So kapag malipara ka, more than 2 hours, kapag wala kang epidural anesthesia, you wait another hour if may epidural anesthesia. So you wait at least 3 hours para makaka-call ka ng prolonged second stage of labor. Pag multipara, mas maikli. Kung iurong mo lang ng 1 hour. 1 hour is without anesthesia, with anesthesia 2 hours. Alright? So that's your prolonged second stage of labor. So let's go back to the case. Walang epidural anesthesia. Bakit ko kinol ko na prolonged second stage of labor? Because, di ba, ang prolonged second stage is more than 2 hours kapag wala kang epidural anesthesia. So ito, nasa 3 hours na siya na fully dilated pero hindi pa rin nag-deliver. So with this curve, prolonged second stage na to. Now, so lagyan ulit natin isa pang component ng partograph. Remember, hindi lang cervical dilatation yung dinidescribe natin, but also the descent of the fetal head. So how do we put that in the partograph? Circle siya. Kasi parang ulo, di ba? Cervix is X kasi cervix X. Cervical dilatation. Okay. So anyway, kung papansinin nyo, hindi bumaba yung head beyond station 0. So meron ba tayong descent disorder? So meron tayong descent disorder here. So it's either, pag sinabi mong descent disorder, meaning wala kang pagbaba ng head. So it could either be failure of descent or arrest of descent. Failure of descent is when there is no descent beyond station 0. Hanggang station 0 lang siya. Hanggang doon lang yung failure of descent. But when you go beyond station 0, meaning +1 below, for more than 1 hour, then you can label your pattern as arrest of descent. Okay? So bakit station 0, bakit station +1 yung arrest of descent? Okay, so the reason behind this is, remember na kapag nasa station 0 ka na, it means na nakapag-engage na yung head. Diba? I kept repeating that. Pag yung leading part mo nasa station 0 or level of the ischio site, engage ka na. Now, descent comes after engagement, usually. Okay? So, ibig sabihin, kapag hindi ka nag-descend beyond station 0, ibig sabihin, wala kang descent at all. Hindi siya nag-progress. Kaya siya failure of descent. Pero pag arrest of descent, kaya siya may time component, is because bumaba naman siya past 0. So after engagement, nag-descend naman siya. It's just that hindi na nag-progress. Yun yung arrest of descent. Okay, a note about failure of descent and arrest of descent. So ito, kaya siya naka-red because yun nga, station 0. Nag-fail na siya bumaba beyond station 0. So again, going back to this curve, ano yung full pattern ng dysfunctional labor mo? This is prolonged second stage of labor, then more than 2 hours without epidural anesthesia in a pre-gravid or in a nullipara with failure of descent. So you will do cesarean section for prolonged second stage of labor with failure of descent. Ganun kahaba yung dysfunctional pattern na isulat mo sa iyong operative technique for your cesarean section. Okay. One note about descent disorders. Yung descent disorder in itself is not an indication for a cesarean section. It should be correlated with either prolonged deceleration phase or prolonged second stage of labor. Okay? Nag-get? Ibig sabihin, kapag halimbawa, mag-CCS ka for arrest of descent, hindi siya complete indication. Kailangan kasama siyang either prolonged deceleration phase or prolonged second stage of labor. Iba si prolonged deceleration has a placing yun. Anyway, so prolonged deceleration phase with arrest of descent, that is the complete indication for your delivery if you will deliver for dysfunctional labor. So ito, bakit prolonged deceleration phase with arrest of descent ang aking call dito? So first of all, tingnan muna natin yung cervical dilatation component. So nasa 9 cm siya. So it means nasa deceleration phase. So ang prolonged deceleration phase kapag multigravid, take note, G2P1 siya. Kapag meron kang at least 1 hour na nasa deceleration phase ka, you have prolonged deceleration phase. That is in a multiparous patient. Okay, with arrest of descent. Why with arrest of descent? If you look at the head of the patient, it's past station 0. It's at station +1. So kita nyo naman, nag-descend naman siya, no? Ito, nag-descend siya, lumampas siya, nag-engage siya kasi lumampas ng station 0 yung bleeding part up to the point of +1. However, more than 1 hour siya at station +1. So nag-arrest na siya doon, tumigil na siya doon. Alright? So kung isi-CS ko itong patient na to, this is my indication or my pattern for the dysfunctional labor. Okay, so nung inaayos ko itong patient na to, I tried to determine the fetal position. The fetal position is left occiput transverse. So ano yung hindi nag-take place dito na cardinal movement of labor? So what didn't take place here is your internal rotation. So hindi nag-rotate si posterior fontanelle towards the symphysis pubis. So hindi siya nag-negotiate or hindi siya pumasok ng maayos into the midplane. Tapos may isa pa akong nanote nung inaayos ko si patient nung 11th hour of labor na nung time na nagkuha ako ng cesarean section. There was already a 2 cm kapot, no? So kailan mo nakikita itong kapot? So yung mga kapot, that is actually a telltale sign na hindi nag-negotiate yung fetal head mo into your pelvic. So nag-i-edema siya because hindi swak yung fetal head diameter with the passageway. Okay? So, considering si patient, doktor na pwede pala yun, pwede pa lang mag-disclose siya ang multigravid patient. Pwede naman, okay? So, kung nakita patient na to, G2P1 yung first niya normal delivery. So, kailan nangyayari yun? Nag-normal na siya before. So, alam mo na adequate yung pelvis niya kasi may lumusot na dyan na baby. Pero, bakit sa second pregnancy niya, nag-disclose siya pa siya? Nangyayari pala yun, doktora? Yes, that happens in cases of asynclitism. So, this is one of the scenarios by which meron kang fetal-pelvic disproportion. Okay? So, tandaan nyo, di ba? Pag sinabi mong cephalopelvic disproportion, you're having problems more of sa passage. Masikip yung passage. Pag sinabi mong feto-pelvic, si baby yung may problem. Either sobrang laki or hindi siya nakaposition well. Okay? So, asynclitism is one of the scenarios by which nagkakaroon tayo ng feto-pelvic disproportion. Bakit? So, the normal asynclitism is, ideally, si sagittal suture, nasa gitna siya between ng symphysis pubis mo and ng sacrum mo. Hindi naman yan always gitna, but more or less, ayun, kaya mag-negotiate dun sa pelvis mo kapag hindi naman marked yung asynclitism mo. Ano ba ibig sabihin ng asynclitism? Asynclitism means you have lateral deflection either towards the sacrum or towards the symphysis pubis. So, when you see anterior asynclitism, yeah, so yung sagittal suture mo, pag pinalpate mo yan, yung sagittal suture is deviated towards the sacrum. Okay? So, nasa baba yung sagittal suture mo. Deflected siya pababa. So, ibig sabihin, your anterior parietal bone is the one that is presenting. Okay? So, nakalimutan kong inutin na itong red, that's your anterior parietal area, yung itong green is your posterior. So, kung mapansinin nyo, si anterior parietal bone, siya yung mas nag-represent. Kaya siya anterior asynclitism. So, huwag kayong malilito ha, ang anterior asynclitism, kaya siya anterior asynclitism is because ang mas nag-represent is the anterior parietal bone. So, we name the asynclitism after the bone, hindi yung direction ng deflection ng sagittal suture. Nag-get? Okay. So, ang sagittal suture, kapag deflected siya more towards the posterior or more towards the sacrum, it's anterior asynclitism because it's your anterior parietal bone that is the leading portion. Alright? So, anong problem pag gano'n? Ang nangyayari kasi pag ganyan is, imagine mo, di ba, ito yung ulo mo. So, instead na ito yung nag-represent na diameter, kapag ikaw ay asynclitic, medyo lumalaki yung diameter na kailangan mag-negotiate into the pelvic. Okay? Yan. Okay. So, anyways, si posterior asynclitism naman, kabaliktaran lang naman siya ni anterior asynclitism. So, your sagittal suture is deflected more towards the symphysis pubis such that your posterior parietal bone is the one that is presenting to you. Okay, I hope that's clear. So, yan yung isa sa mga scenario by which a multigravid patient na previously nag-normal, nag-dispose or nag-dysfunctional labor. Pwedeng asynclitic yung patient. Okay, now we move on to the operative vaginal delivery and your CS delivery. Okay, so we go back to this patient. No, so G2P1 multigravid patient, ruptured bag at the 6th hour of labor. So, nung 4 cm siya, nung 6th hour of labor, nag-rupture yung bag of waters niya. Adequate naman yung contraction. And then, may epidural anesthesia tong patient na to. So, first question, anong stage of labor? So, we look at the cervical dilatation. So, fully dilated. So, nasa second stage na yung patient natin. Okay, so nasa second stage na siya. Meron na siyang prolonged second stage. So, for me, yes, this is a case of prolonged second stage. Kasi, di ba, ang prolonged second stage of labor in a multigravid patient ay more than 2 hours. So, ito in fact, 3 hours na siya, 1, 2, 3, na fully dilated pero hindi pa rin daw nag-deliver. Pero bakit hindi mo tiniis, doktora, ay prolonged second stage siya pala? Kasi kung titingnan mo, nag-descend naman yung head, so nagpa-progress siya. So, naghintay lang yung OB niya. Saka, mag-ano ka pa ba, mag-CS ka pa ba pag nasa +4, +5, masyado na yung mababa for you to perform cesarean delivery. Pero bakit hindi pa nag-deliver yung patient? So, pwedeng at this point, mayroon ka ng poor maternal effort. No? Okay? So, ito, more than 2 hours na siya. So, in a multipara, so prolonged second stage ito. So, ayun, for maternal effort kasi kanina pa siya nag-push. So, ano nang gagawin mo? Ano nang option mo? So, one thing that you can do is to perform outlet forceps extraction. Okay, you see this picture? This is an example of a symptom outlet forceps. Okay? So, ito yung ginagamit namin para mapadali yung second stage of labor. So, when do we use forceps? So, first is if there is a maternal indication. What do you mean by maternal indication? Kapag ayaw natin mapagod yung mother, meaning meron siyang comorbid condition na hindi mo siya pwedeng ipapush. Example, if she's gravidocardia or may sakit siya sa puso, meron siyang pulmonary problem, or meron siyang neurological condition by which hindi siya makakapag-push. So, isa yung indication for outlet forceps extraction. So, for a patient, pasok siya dito, prolonged second stage. So, another indication for OFE or outlet forceps extraction is kapag si baby naman yung nahihirapan. What if naka-continuous monitoring ka, tapos nasa station +4, +3 na siya, hindi pa rin masyado, tapos malapit na sa outlet ka na, pero hindi pa rin talaga nag-deliver si patient, okay? So you can perform outlet forceps extraction in that case. So another one is shortening of second stage for maternal benefits. So pwede pasok dito si patient natin, no? So pwedeng for maternal effort, so to help the mother, you perform outlet forceps extraction. Okay. So these are the criteria for outlet forceps extraction. Okay, bakit important, Doctora, yung outlet forceps extraction? Kasi may iba-ibang kinds of forceps extraction. Pag sinabi mong outlet, it means that the scalp is already visible at the introitus without separating the labia. Ito yung tinatawag namin crowning. Nandiyan na talaga yung ulo. Hindi mo kailangan i-part with your fingers yung labia para makita mo yung scalp ng baby. Second, the fetal skull has reached the pelvic floor. The sagittal suture is in the anterior posterior diameter, or ROA, or LOA, or ROP, or LOP. Okay, guys, basta wala sa transverse position. Kaya important na marunong kayo mag-determine ng fetal position. Okay, fetal head is at or on the perineum, and the rotation does not exceed 45 degrees. In other words, basta wala ka sa transverse position, pwede kang mag-outlet forceps extraction pag na-fulfill mo yung other criteria. Maliwanag? So ito, guys, yung ibang criteria for the other kinds of forceps extraction, but this is more of for, theoretical na lang talaga, because we rarely perform the low forceps extraction and the mid forceps extraction. Outlet forceps extraction lang talaga yung important. So kung may memorize kayo dito, it's the criteria for OSC or outlet forceps extraction. So, ano yung low forceps? At tandaan nyo lang dito yung station. It's greater than or equal to +2, pero hindi pa niya na-fulfill si outlet forceps. Yung mid forceps, sobrang taas nito, between station 0 and +2. Okay? So, ito yung prerequisites, guys, for outlet forceps extraction. So, ito yung mga dapat mong ma-fulfill para makapag-OSC ka. I'll give you a mnemonic para madali nyo siyang maalala. So, the prerequisites for your forceps, outlet forceps extraction or OSC are forceps. Okay? F stands for fully dilated cervix. Bakit ito important? Because pag hindi fully dilated ang cervix mo at nag-insert ka ng forceps, pwede mong malacerate yung cervix. Okay? Pwede mahagip mo siya ng forceps. We don't like that. Okay, second, dapat occiput or vertex presentation. R stands for ruptured membrane. C, CTB is not suspected. E, engaged head. Dapat din experience yung operator, goes without saying. And another E stands for empty bladder. Okay? Kasi pwede mo rin mahagip yung bladder if full yung bladder mo tapos nag-insert ka ng forceps. Okay, P stands for position known, meaning alam mo dapat na hindi siya transverse in position. P, painless. Kailangan meron kang adequate anesthesia. So typically yung mga in-OSC namin, either naka-saddle block yan or naka-epidural anesthesia or kapag naman ka talaga at the very least o dental block. Okay? F stands for size estimated or fetal weight is estimated. So these are the other prerequisites na I'll leave that up to you. Ito kasi mga hindi masyadong common, di ba? Yung mga fetal coagulopathy, demineralization disease. So these are the other prerequisites, but the most common prerequisites na sinecheck namin before we perform OSC are these forceps. Okay? Madaling maalala si forceps. Okay. So OSC is a form of assisted vaginal delivery. Ngayon, kung ayaw mo ng OSC, you can perform vacuum extraction. So that's another form of assisted vaginal delivery. Ang maganda kasi vacuum extraction, less maternal trauma siya. Diba? Kasi you won't have to insert an instrument into the pelvic cavity or into the birth canal. Yun yung, ang tapos naman si vacuum extraction, since sinasuction yung head ng baby, ang modality mo for this is pwede silang mag-subgaleal hematoma. So ito yung sa mga feared ko when I perform vacuum extraction. So ito yung isang example ng vacuum. Si Kiwi, dito ako familiar. So this is another vacuum extractor. So may bell naman siya. So ito yung si Kiwi na vacuum. Ito yung nilalagay mo sa flexion point, this one. So yeah. So ano ba yung flexion point? So si flexion point, dyan mo ina-attach yung vacuum. It's 3 centimeters from the posterior fontanelle and 6 centimeters from your anterior, from your anterior fontanelle. So dyan mo siya nilalagay para ma-facilitate yung extension ng head, okay? Palabas, to facilitate the expulsion of the fetal head. So, sa flexion point mo nilalagay yung cup ng iyong vacuum para ma-maximize mo yung extension, alright? Yun yung cardinal movement na pinafacilitate mo yung vacuum extraction. So, kailan mo masasabi na nag-fail ka sa vacuum extraction? After 2 to 3 pop-off. Ibig sabihin, di ba, na-suction yan sa ulo ng baby, tapos na-detach, di ba? Hinihila mo kasi siya, tapos na-detach from the head of the baby. So, after 2 to 3 tries and a total time of 15 to 30 minutes, you must perform cesarean delivery for failed vacuum extraction, okay? Huwag mo nang pilitin kapag hindi talaga kaya ng vacuum, hindi kaya ng suction or ng pressure from the vacuum. Okay. Now we go back to our index case. Remember, we have an index case. So si OB, 35-year-old trainee, she was already fully dilated on the 15th hour of labor. Okay, ito yung IE mo sa kanya. You were able to palpate fetal parts forming a triangular shape. So at the base of the two bony prominences, at the base are two bony prominences. So na-imagine nyo ba, kung ito yung triangle, sa base ng triangle may bony prominence, tapos doon sa tuktok, sa apex niya, merong opening. Nung in-insert mo yung fingers mo doon, no resistance was met, okay, into that opening. First question, is this breech or cephalic presentation? So, the answer here is cephalic, specifically face presentation. Okay? So, most likely ganito siya. So, nakakalito talaga ang IE ng breech at ng face presentation. So, how do you differentiate? So, sa face, as I mentioned, triangular shape siya. Kasi, yung malar prominences that forms the bony prominences sa base, tapos yung apex niya is the mouth. Ito yung, ang description sa Williams is yielding, meaning walang resistance when you insert into that opening. Pag breech naman, ang difference niya, kung triangle sa face, sa breech, yung ischial tuberosities mo or the bony prominences and the anal opening form a straight line. Okay? So, there is resistance in the opening because may sphincter yung anal opening mo. There could be with or without meconium. So, obviously, pwede may meconium. So, ito yung sasabi ko na triangular shape sa face. So, yung malar prominence mo and the mouth will form a triangular shape on IE. And then, sa breech naman, one straight line siya. So, yung buto, yung opening, saka yung another buto, which are your ischial tuberosities, yan yung nagpo-form ng straight line. So, dyan mo ma-distinguish between the face and the breech presentation on internal examination. Okay, so si patient natin ay face presentation. Now, next question. Ano yung fetal position? Ito muna sa left. So, di ba, ang ating arbitrarily chosen structure is the chin or the mentum. So, this one is mentum anterior. Binaliktad ko lang yung picture. So, itong nasa right, anong position ito? Itong nasa right, since yung chin ay nasa sacrum, this is mentum posterior. Okay, nasa direct posterior position siya. Okay, next question. Between the two, alin ang pwedeng mag-vaginal delivery? Is it mentum anterior or mentum posterior? Okay, ang correct answer dito sa question na to, in which fetal position can the patient deliver via normal spontaneous delivery, it's your mentum anterior. So, bakit si mentum posterior hindi pwedeng mag-vaginal delivery? It's because the bregma or the brow of the baby and mentum posterior will impact against the symphysis tubis. That is kung umabot siya dyan sa pelvic outlet. The problem, another problem with your mentum posterior is that this position precludes flexion of the head. Tingnan mo naman, hindi siya mag-flex. So, this position will not engage properly or descend properly into the birth canal. Okay? So, kapag mayroong mentum posterior position, this is in fact an indication for cesarean delivery. Okay? Maliwanag? Okay, let's go back to the index case. When you review her monitoring, mataas pala BP niya. In fact, 140/80 yung systolic over a diastolic of 100 to 110. So the patient is still in pain. And super in pain pa rin siya despite being on epidural analgesia. And then you noted that this patient has been on oxytocin drip or oxytocin infusion since entering the active phase. So ano yung active phase? Between 4 to 6 centimeters. Okay? So sabi natin 4 centimeters, pina-oxy na siya. Okay, so matagal siyang naka-oxytocin. And one thing that you noted, the panic yung contractions, no? Sobrang tigas ng mattress ng patient. And then ang monitoring, ayan, meron kang prolonged deceleration. So in distress yung baby mo. So anong consideration mo for this patient? Meron kang hypertensive na advanced maternal age, very much in pain, naka-oxytocin drip for say a long time, tapos tetanic na yung contractions mo, and then meron kang fetal distress. So you could be dealing with a case of abruptio placenta. So bakit abruptio placenta and ano ba yung abruptio placenta? When you say abruptio placenta, this means that your placenta separated before the baby is expelled, okay? Meaning, di ba dapat ang normal, mauna muna si baby sa yung placenta mo. But what happens is, nag-separate na yung placenta mo even before nag-deliver si baby. So, abruptio placenta, ang typical presentation niya is painful vaginal bleeding. But like in our patient, kahit wala siyang vaginal bleeding, pwede pa rin siyang case of abruptio kasi meron tayong tinatawag na concealed hemorrhage. So, there are cases like this, no? Kasi ibig sabihin nito, yung position ng placenta mo or yung implantation niya sa uterus is such that kapag nag-separate siya, hindi lalabas yung retroplacental blood clots, okay? So, compared with this abruptio placenta, yung implantation site niya is such that kapag nag-separate siya, pwedeng may labasan or pwedeng mag-present ng bleeding yung patient. May lalabasan yung retroplacental hemorrhage. Okay? So, ang pangit abruptio placenta is that because the mother is bleeding, then the baby is also bleeding. So, this causes the fetal distress and in worst cases, nag-fetal demise or nag-stillborn yung baby. Okay? So, in some cases, as I mentioned, pwedeng concealed yung hemorrhage mo versus apparent na which happens most of the time in abruptio placenta. Pwede rin siyang partial, pwede rin siyang complete. Pag partial, it means na part lang ng placenta mo yung nag-separate. Pag complete, the entire placental bed separated from the underlying myometrium, okay? So what are the predisposing factors? So hindi ko na iisa-isahin, but essentially, ang predisposing factor mo, ang common thing about all these predisposing factors is that pangit yung uteroplacental unit mo. Hindi maganda yung vasculature. So this happens in cases of, example lang, hypertension. Remember, di ba, vasoconstricted instead of vasodilated ka in cases of hypertension. So pangit yung attachment baseline ng placenta mo to your uterus. So advanced maternal age is also a risk factor. So I highlighted this because this is what's present in the patient. So bakit naka-italicize ko? Because this is the most important predisposing factor. Kapag may previous placenta abruptio ka, likely, sa mga susunod mo, mataas yung chance mo na mag-abruptio placenta ka ulit. So we watch out for that in the subsequent deliveries or labor of the patient. Now, what are your precipitating factors? If your predisposing factors are maternal comorbid conditions, your precipitating factors, events naman to. So example of precipitating factors that could cause abruptio placenta is trauma. So because of the trauma, there will be sudden shearing forces that will tear away the placenta from its implantation. Pwede rin because of sudden decompression, like in cases of rupture of membranes with polyhydramnion. So imagine you have a well-distended na amniotic sac and then suddenly puputok yung bag of waters mo. So the decompression could also cause tearing away of the placenta from its implantation site. So ito yung mga precipitating factors for events that could lead to abruptio placenta. Primarily, it's a clinical diagnosis, okay? Most of the time, hindi na namin ito na-ultrasound because nag-emergency na kami na delivery for these patients. Pero kung sakaling makapag-ultrasound ka, what you will find or what you could find is retroplacental clots. So this represents the hemorrhage between the placenta and its implantation site. Negative findings on ultrasound do not exclude placental abruption. Meaning, kung hindi mo nakita yung retroplacental clots, hindi ibig sabihin nun, hindi ka nag-abruptio. Okay? So, hindi mo talaga kailangan ng ultrasound para mag-diagnose ng abruptio placenta. Magiging supplemental lang siya to your clinical diagnosis. I diagnosed her clinically to have abruptio placenta with non-reassuring fetal status, so I immediately performed emergency cesarean delivery. Okay, now we move on to another form of delivery, which is cesarean delivery. So, hindi ko naman sa inyo i-require na kauluhin yung steps ng CS delivery, but at your level, ang importante ay maintindihan nyo kung ano yung indication for CS delivery. So, kailan kami nag-CS? One is, an indication could be because the patient has a scarred uterus. So, prior to cesarean delivery, tapos halimbawa, consent for vaginal birth after cesarean section, that is an indication. Second, pwedeng there is abnormal placentation, such as in cases of morbidly adherent placenta. Pwede rin meron kang placenta previa or when the placenta presents before the fetal part. Okay? So kapag ganun, hindi ka pwedeng mag-normal delivery, otherwise mag-bleed ka. That is why mag-abdominal delivery tayo or CS delivery. So prior classical hysterotomy or prior CS. Kaya remember, di ba, sa history taking, the reason why we have to know kung anong klaseng CS is because kapag classical yan, kapag classical ang scar, hindi ka pwedeng mag-normal. Mataas kasi ang chance mo for uterine rupture for your classical CS scar. So hindi siya pwedeng gawin. Okay? Hindi siya pwedeng mag-normal. Okay? So the next indication is having an unknown uterine scar type. So the precise reason for this is because pwedeng yung prior cesarean section scar type mo is a classical CS scar. So kapag ganun, kapag hindi ka sure kung anong klaseng scar siya, wala siyang operative technique or you can contact the prior OB na nag-CS sa kanya, wag mo na siyang i-vaginal birth after cesarean section, i-repeat cesarean section mo siya. Okay? So ano pa? Uterine incision diseases, that's another indication. Okay, so ano pa? Select prior surgery. So examples of these are your myomectomy. So kapag status post myomectomy yung patient mo, or what else? Status post corneal wedge resection for an interstitial pregnancy. So yung mga ganong surgeries, mataas kasi yung chance mo for rupture. Kung hindi mo na i-risk na mag-vaginal birth sila after cesarean section, you will perform CS deliveries for those patients. So ano pa? Tumor previa. So kung si placenta previa is the placenta present before the fetal part, si tumor previa is a term that we use if there is a uterine mass, for example, a myoma, in the lower uterine segment, precluding the normal delivery of your fetus. Okay? So tumor previa. So another indication for CS delivery is cervical cancer for obvious reasons. HIV and HSV infection. So herpes simplex, pag may active ka na herpes simplex lesion, you don't perform vaginal birth. HIV actually depende to sa viral load ng patient. Pag mataas yung viral load, you don't allow vaginal birth for these cases, yung cesarean delivery mo, to reduce the risk of the baby getting exposed to the maternal fluid. Perimortem delivery, so ito yung ayaw na ayaw mo, no? Perimortem delivery means nag-arrest yung mother mo but you have a live baby na viable. Okay? So kapag gano'n, you perform immediate CS delivery, peripartum delivery yung tawag namin doon. So what are the maternal fetal indications? CPD. Okay, na-discuss natin to extensively kanina. Failed outlet vacuum delivery, placenta previa or placenta abruptio. So na-discuss na rin natin to. Again, another type of indication for CS delivery or fetal indication. So kapag si baby naman yung in distress or si baby yung may problem. So one indication, which is the case of our patient, non-reassuring fetal status. Second, malpresentation. Specifically, ito yung mga examples na nag-CS delivery tayo. Transverse life, footling breach, mentum posterior. So itong mga to, hindi siya pwedeng mag-normal delivery, CS delivery or abdominal delivery for them. Macrosomia, depends on the macrosomia. Pag may certain weight criteria tayo for macrosomic babies na hindi pwedeng mag-normal delivery. Otherwise, you run the risk of pushing them towards shoulder dystocia. Congenital anomalies na hindi pwedeng mag-normal delivery. For example, sobrang laking head from hydrocephalus. So obviously, we can do vaginal delivery for that case. We perform CS delivery. Abnormal umbilical cord Doppler study. So for example, meron kang reverse and diastolic flow, kailangan mo na i-deliver immediately. So you perform CS delivery. So that's a fetal indication. Okay, last indication that we cited. So these are just some of the indications. Pero this final indication is an example of which is thrombocytopenia. Basically, any blood coagulation or coagulopathy disorders in the baby that will increase the risk of inducing intracranial bleeding in the baby. So hindi nila mawithstand yung vaginal delivery. Hindi mo na yan pinaka-normal. Okay? Hindi mo na yan pinaka-fully dilated. I-elective cesarean delivery mo na yan. Okay? Yan. So yung ibang signs, sige, pang OB na yan, pang OB levels na yan. Ang mas important sa akin na alam nyo is yung uterine scar or the hysterotomy scar. Okay? So ang pinaka-common is your low transverse cesarean section or your Kerr incision. So this is the most preferred and this is the most common. So we place a transverse scar along the lower uterine segment. So this is associated with less bleeding and risk of rupture. So kaya ito yung pinaka-preferred namin. Okay? So imagine guys, if we cut above the lower uterine segment, mas madugo siya because mas makapal yung myometrium mo during this part. Remember, di ba, pag confirm na yung patient, kapag nag-engage na siya, turned out na itong lower uterine segment mo. Okay? So mas manifest yung myometrium dito. Therefore, mas madali siyang i-enter when you perform hysterotomy and less yung bleeding. That is why this is the preferred type of scar, the low transverse. Now, if you have a low transverse, it means that you have a low vertical. Okay? So low vertical, same lang din siya, sa lower uterine segment siya, but it is in a vertical position. Okay? In a vertical orientation, yung pagkat namin ng scar. Now, the other common uterine scar is your classical cesarean section scar. Okay. So, sa classical CS, above na siya ng lower uterine segment. So, obviously, mas madugo ito. Pero bakit namin ito ginagawa? Okay? Despite being bloodier, being more difficult, and being more prone to uterine rupture for subsequent pregnancy. So, we have certain indications for your classical CS delivery. So, one is densely adherent bladder. So, imagine nandito yung bladder mo, diba? So, malapit siya sa lower uterine segment. So, pag meron kang densely adherent bladder, that precludes entry into the lower uterine segment. So, hindi naka-expose yung lower uterine segment mo. So, because of that, wala kang ibang choice but to cut above the lower uterine segment through a classical CS scar. So, other indications, kapag may myoma ka dito sa segment na to, obviously, hindi mo yan na LTCS or low transverse CS, so mga sa classical ka. Cervical cancer. So, bukod sa bloody siya, if you cut through the lower uterine segment, in cases of cervical cancer, you run the risk of cutting through the tumor when you do LTCS in pregnant patients with cervical cancer. So, classical ka talaga dyan. So, massive maternal obesity precluding safe entry. So, entry or safe access to. Safe access sa lower uterine segment mo. This is a very rare indication, guys, I'm telling you. Pero this is in the book. So, pag meron ka nito, you perform classical cesarean section. Placenta previa with anterior implantation. Technically, pwede mo siyang gawin eh. Pwede kang mag-LTCS naman with placenta previa with anterior implantation. But, guys, the caveat is you run the risk of cutting through the placenta, therefore causing massive hemorrhage. So, some OBGYN, they perform classical cesarean section for this case. So another indication for classical cesarean section is back down transverse lie. Ano ibig sabihin ng back down transverse lie? Remember, pag transverse lie, since hindi yan pwedeng mag-normal delivery, immediately cesarean section agad yan. So kung ano klaseng scar, depende kung back up or back down siya. Pag back up yung patient mo, pwede kang low transverse cesarean section kasi yung fetal parts mo nandun siya sa lower uterine segment. So pwede mo siyang mag-gas to deliver the baby. However, kapag back down siya at nag-low transverse incision ka sa lower uterine segment mo, hindi mo ma-access yung fetal parts. Therefore, mahihirapan ka mag-deliver ng baby kapag LTCS. That is why, for back down, we do classic CS, okay? Yun yung indication natin, yung mga indications natin for classical cesarean section. So again, kapag may classical CS ka, hindi ka pwedeng mag-vaginal birth after cesarean section because of the high risk of uterine rupture. So sino yung mga pwedeng normal after CS? So kung patient mo na CS siya, pero reassuring fetal status, tinatanong niya, pwede daw ba siyang mag-normal? Kung she says na pwede bang mag-normal, pwede bang mag-normal delivery after niya ma-CS? So, ang sasagutin ko kanya, depende po, ma. Depende, so paano mo naman masasabing depende? So, sino-sino ba ang pwedeng mag-VBAC or vaginal birth after cesarean section? So, these are the common criteria ng mga pinaka-VBAC namin. Una, if there is only one low transverse cesarean section, kasi ito yung lowest rupture rate. Therefore, kapag classical CS, automatic, hindi mo ipapa-VBAC. Okay, non-recurring indication for prior CS, meaning dun sa next pregnancy mo, wala na yung previous indication for your cesarean section. So, examples are malpresentation. Kung dati okay, tapos yung next niyang pregnancy ay cephalic na, baka naman, pwede siyang mag-normal. For example, another example is kung placenta previa dati, yung sa sumunod na pregnancy, hindi na sa placenta previa, pwede rin siyang mag-VBAC. Or kapag yung dati non-reassuring fetal status, hindi naman ibig sabihin nun, di ba, na non-reassuring na siya ulit sa next pregnancy niya. So, that is another possibility na pwede kang mag-VBAC. Okay, what else? Dapat yung inter-delivery interval mo, meaning, yung CS mo to the next CS is more than 18 months. Bakit? Anong mangyayari kapag na-CS ka within 18 months from your prior cesarean section? You have 3 times the risk of incurring CS scar rupture. Okay? Pwede mag-rupture yung matrix mo niya. So we don't want that. So ni-advise mo yung patient mo, ma'am, at least 1.5 years ka dapat na hindi po mabubuntis or hindi cesarean section para po pwede kayo mag-normal sa susunod. Okay? Yung sasabihin mo. Informed consent. Okay? It goes without saying na dapat si patient agree siya na mag-VBAC. Okay? Because this is also a high-risk delivery for them. And ito yung i-emphasize nyo sa patient nyo. Okay? So kung halimbawa meron siya nitong mga na-fulfill niya itong mga criteria na to, ang isa pang importante na take home message for your patient, dapat double set up siya sa next delivery niya. Ang ibig sabihin ng double set up, dapat nasa setting siya where, halimbawa, mag-normal delivery siya. But kung sakaling kailangan niya mag-emergency cesarean section, kung saan siya manganganak, dapat capable siyang, dapat CS capable or CS delivery capable yung institution na yon. Therefore, ang clinical check-up niya hindi pwedeng sa line-in, hindi pwedeng sa health center, kailangan sa hospital. Okay? That is one thing that is important to emphasize to your patients na mag-undergo ng cesarean section. Okay? If they really want to deliver via VBAC or actually via repeat, okay, pag uterus automatic na yan, dapat hindi sila sa line-in or sa health center. So kindly emphasize that to your patient if you have patients who will undergo or who underwent cesarean section delivery. Okay, so finally we move on to the third stage of labor. So again, ano yung third stage of labor? This is from fetal delivery up to the part when the placenta is delivered. Okay? So ano yung important malaman sa third stage of labor? First is signs of placental separation. So ano yung mga signs of placental separation? So there are 4. Sudden gush of blood. So meaning, nag-detach na yung placenta mo yan pag meron ng sudden gush of blood. Second, the fundus becomes more globular and more firm. Third, there is lengthening of the umbilical cord because of the detachment now of the placenta. And fourth, there is rise of the uterus into the abdomen. So usually yung mga residents nyo bago ipagawa sa inyong placental delivery, they might ask you these 4 signs of placental separation. Okay, so dapat sa ulo nito. Okay, so another thing na important yung malaman is the active management of the third stage of labor. Meron tayong acronym for this, AMPFL. Okay, so yung mismo acronym mahaba. So just call it by the name active management of the third stage of labor. Okay, so para may iba po bang forms of management ng third stage of labor? Meron tayong tinatawag na expectant management. Sa expectant management, hinahayaan lang natin continuously lumabas yung placenta, either through gravity or spontaneously, basta lang siyang lalabas, wala kang actively gagawin. So yung active management ng third stage of labor, it has 3 components. Early cord clamping, controlled cord traction, and immediate administration of prophylactic oxytocin or your first line uterotonic. Doktor, bakit dalawa yung nakasulat under cord clamping? May early cut at may delayed cord clamping. Okay, just to clarify, ang nasa Williams kasi early cord clamping. Whereas locally, ang ginagawa natin, and what is according to our CPG from POGS is that we perform delayed cord clamping or properly timed cord clamping. Meaning, we wait for the pulsations to stop before we perform cord clamping and cutting. So why? Because this decreases the risk for fetal anemia, okay, or neonatal anemia. So yun yung pinaka-facilitate natin when we perform delayed cord clamping. Doktor, bakit naka-highlight kung third active management ng third stage of labor or your oxytocin administration? It's because this is the most important aspect or the most important part of your AMPFL. Okay? Kasi basically, kaya mo ginagawa to is to prevent postpartum hemorrhage. Therefore, ang pagbibigay mo ng oxytocin and other prophylactic uterotonics, yun talaga yung pinaka-important and pinaka-effective na means to prevent postpartum hemorrhage, okay, or bleeding during the postpartum period. Okay, so what are the other uterotonics aside from your oxytocin? Oxytocin being the first line. So si oxytocin, you can either use that intramuscularly or through IV infusion. So the other uterotonics, kapag halimbawa hindi pa rin tumitigas yung matres mo or nagpo-contract after administration of oxytocin are as follows. You can give the patient methyl-ergonovin maleate. Ang contraindication dito is hypertension. We also ask the patient if they have bronchial asthma. So we don't give metrogen or methyl-ergonovin maleate in cases of hypertension and bronchial asthma. We can also give carbetocin, which is an oxytocin analog, or we can give carbopros. So yung carbopros, this is a synthetic prostaglandin analog, specifically prostaglandin F2 alpha. Si F2 alpha kasi siya yung responsible for vasoconstriction and contractility of your uterus. Okay? So ano yung contraindication of carbopros? Same as metrogen, we don't give that in the presence of asthma and hypertension. Okay? So these are your other uterotonics. Okay, meron po ba doktor na prolonged third stage of labor? Yes, meron prolonged stage of labor na tinatawag. Ito yung kapag hindi pa rin nag-deliver yung placenta more than 30 minutes. So that's what you call prolonged third stage of labor. So ano yung management mo for prolonged third stage of labor? You do manual removal of the placenta or manual placental delivery. Okay, so ang gumagawa nito is yung mga OB ninyo, don't perform this nang walang anesthesia yung patient. So hindi nyo kailangan alamin yung technique behind manual removal of the placenta, but essentially we insert our hand into the uterine cavity and then we peel off the placenta from its implantation kapag nag-prolonged stage of labor. Bakit namin ito ginagawa? Because as long as the placenta is there, the uterus will keep breathing. Okay? So kailangan namin siyang i-remove manually instead of doing just cord traction, controlled cord traction. Alinaw? Alright, so in terms of episiotomy, what we perform is, or what we practice is restricted use versus routine use. Meaning kung mukha naman siyang lalabas even without episiotomy, we forgo the episiotomy. You don't need to cut the perineum. Just, hindi siya parang routine na, unlike before na, left and right na, episiotomy kami. What's recommended now is restricted use. So, hindi lahat episiotomy pa kayo guys, kahit pinigabid pa yan. So what are the different kinds of episiotomy? The first one is MER, or median episiotomy and repair. Yung kaya sa MER, median episiotomy and repair. So the first kind of episiotomy is median. So kaya siya median is because sa midline kami nagka-cut. Ayan. So ito, ang pinapakita ng picture na to is yung degrees ng laceration. So yung mga perineal laceration, depende siya kung ano yung structure na nasisira mo. So the first degree is this one lang. Portion lang yung na violate niya or nalalacerate niya sa konting skin. When you say second degree laceration, it means na ang nalacerate mo is the perineal body. So kapag nalacerate mo yung perineal body, ang nalalacerate na muscles is your bulbous sponjosus. So ito siya, itong bulbous sponjosus, ito yung muscle dito, and your superficial transverse. Ayan. So ganito yung fibers ng superficial transverse na muscles. Okay, let's skip this picture kasi ito yung last dapat. Dito tayo sa baba muna. Ito yung third degree laceration. So when you say third degree, you lacerate the anal sphincter. Ngayon, this is further subdivided into 3A, 3B, 3C. Si 3A, less than half lang nung external anal sphincter or your EAF, yung nalalacerate. Pag more than half, that's your 3B. 3C, the entire EAF or the entire internal anal sphincter is torn, and then part of your internal anal sphincter is also lacerated. Pag fourth degree, umabot ka na sa rectal mucosa. Now, what is the other kind of episiotomy? The other kind of episiotomy is right, but towards the maternal right is tuberosity, right mediolateral episiotomy. So, ang namin dyan, ang pag sinusulat namin siya sa procedure, NSD with RMLER, with repair na kasi kaya may R. Okay, so ano yung mga advantage and disadvantage ng each kind of episiotomy? So, sa median episiotomy, less painful yan, mas maganda yung healing. However, ang sa kanya, mas at risk ka of incurring fourth degree laceration or even third degree laceration. Okay? So, kapag halimbawa, pangit yung pagkaka-repair, pwede silang mag-rectovaginal fistula or pwede silang magkaroon ng incontinence problems, hindi man sila magkaroon ng problems regarding rectovaginal fistula. So, we don't like that. If halimbawa, hindi naman masyadong okay. So we don't like that about median episiotomy. For right mediolateral episiotomy naman, ang hindi natin gusto about it is it's more difficult, no, to repair. So mas pangit din daw yung healing ng right mediolateral episiotomy. Pero ang maganda sa kanya is you avoid the sphincters and thereby you avoid the rectal mucosa, the anal mucosa when you perform right mediolateral episiotomy. So yun yung advantage ni RMLE over MER or median episiotomy. Okay? So that is the end of the obstetrics part. Now we'll be moving on to the other aspect of our practice, which is gynecology. So guys, sobrang dami ko pang hindi na-cover sa OB, but I believe yung mga na-mention ko sa inyo, yung mga naturo ko sa inyo, yun yung mga essentials and must know. So hopefully, through what I taught you, marami kayong mabaon sa inyong rotation in the OPD, in the emergency room, labor room, delivery room, operating room, kahit pag nag-rotate na kayo as ward interns and killers. So yun na, see you in the next part, which is gynecology.